All right, we are right at 10. David, should we go ahead and get started?
Sounds great, Deb.
Okay, perfect. Well, good morning, everybody. I'm Deb Howery. I'm the designated federal official for our ACD. Welcome to the meeting of the Advisory Committee to the Director. Please note that the closed captioning link has been provided in the chat box for your convenience. And now I'll turn it to our chair, Dr. David Fleming.
Thanks, Deb, very much. Good morning, everybody, and welcome to the February ACD meeting. This meeting is one day and will be entirely virtual, but it's still good to see people's faces. Our next meeting is going to be in May, and that is scheduled right now for Atlanta in person for 2 days. As today's first order of business, I'd like to start with a quick roll call and declaration of conflict of interest. To start off with, I'm here and I have no conflicts. Ada Adamora.
Hi, I'm here. I've consulted for Merck and Gilead, but I have no conflicts related to this meeting.
Thanks, Ada. Daniel Dawes.
Morning, present, and I have no conflicts of interest.
Great. Crystal Gary.
Good morning. No conflicts of interest.
Hi, Crystal. Lynn Goldman.
Good morning. I have no conflicts of interest for this meeting.
Good to see you. Rachel Hardiman.
Good morning. I have no conflicts of interest to report.
Hi, Rachel. Octavio Martinez.
Morning, David, and no conflicts of interest.
Good morning, Octavio. Rhonda Meadows.
Good morning. This is Rhonda. I have no conflicts of interest.
Hi, Rhonda. Julie Morita. Julie is on her way, and so I know that she's joining. She said she might be a few minutes late. And her compatriot, Nirav Shah, is also going to be joining the meeting late. Joshua Sharfstein.
Good morning. No conflicts for me. Thanks, David.
Good to see you, Joshua. Thanks. Jill Taylor.
Good morning. No conflicts, David.
Hi, Jill. And Monica Valdez-Lupi.
Good morning, David. No conflicts.
Good morning, Monica. So the great news is that we have the required quorum, which for this meeting is 8. As a couple of housekeeping reminders, ACD members, please keep your cameras on as much as possible, particularly during the discussion. And if you want to speak, just use the raise your hand feature like we've done in the past. And for those of you that are panelists and presenting today, you do have the flexibility of changing the modes from speaker mode to gallery, whatever works best for you. So we have a busy meeting today. In a few minutes, we're going to hear from Dr. Walensky, and a bit later in the meeting, we're going to get an update from CDC on their workforce initiative, including a discussion of their large workforce infrastructure grant that has just gone out to state, tribal, territorial, and local health departments. We're also going to have presentations from our 3 ACD work groups. First up after the director will be a report from our data and surveillance work group. And then later in the meeting, we'll hear from our health equity work group, including a final vote on one part of their report and an opportunity for all of us to have a little bit of a deeper discussion about some work they're going to be doing on two other aspects of their work. And then closing out our presentation later in the afternoon on the East Coast will be an important report on COVID laboratory testing that our laboratory working group will present to us. There'll be a number of recommendations in that report, and we are looking forward to a vote on those recommendations. It's a little tough in these virtual meetings with some important votes to know exactly how much time to schedule. We've tried to err on the long side, and so it's possible that we will end a little bit early today, but we'll just have to wait and see. And finally, as a reminder, our November minute meetings are available in the official ACD record, or as the work group meetings that have been conducted since our last meeting. So for the first section of our meeting, it's really my pleasure to once again introduce Dr. Rachel Walensky to give her report. As the CDC director, Dr. Walensky really doesn't need an introduction, but I enjoy doing it anyway. The last couple of months have been particularly busy for CDC, and there's been some significant progress on the Moving Forward initiative, which I expect we might hear at least a little bit about. So Dr. Walensky, welcome, and you have the floor.
Thank you so much, David, and good morning to all of you. Good early morning to some of you who are on different time zones. It's wonderful to be with you all, especially as you begin another year. I'll start the way I often do with a just big round of thank yous for all of the hard work and productivity, both as part of ACD as a whole and for being part of important work groups on equity, data and surveillance, and laboratories. Counsel and wisdom I have come to rely on. I'm delighted to announce, you probably already noted, that Dr. Deborah Howery is now the designated federal official for the ACD. CDC is grateful, and I am personally grateful for John Auerbach's service in that role, and we wish him wish him well as he opens a new chapter. Dr. Howery has been serving as our acting principal deputy director since the retirement of Dr. Ann Schuckett 18 months ago, and she has also moved into her new role as the agency's deputy director for program and science and the chief medical officer of the agency. She will continue to serve as acting principal deputy director until Dr. Nirav Shah of Maine joins CDC as principal deputy director next month. Your agenda for today is packed with discussions of what has been considered by the work groups, including a deep dive, as David mentioned, into the recommendations of the laboratory work group. Speaking of the laboratory work group, I just want to extend my deep gratitude for the leadership of the co-chairs, Dr. Jill Taylor and Dr. Josh Sharfstein, and all of the enormous time and effort of the members who've put into their proposed action steps. Given the strong interest in the CDC's reorganization process, I know you're going to be talking a lot about lab this afternoon, but I thought I would give you a high-level update on our reorganization process and progress. The organizational changes you've seen were developed by CDC senior leaders with extensive staff input through 10 strike teams focused on public health data, global health, advancing equity, science, policy, laboratories, and more. So taking their input into consideration, we have submitted a proposed organizational structure to HHS, and the prior structure and the proposed new structure are in that printout that you have received. Ultimately, the proposed changes for our processes are about eliminating reporting layers, breaking down silos within the agency, putting our foundational public health capabilities, and facilitating bi-directional communication and accountability. So the first change you may notice in our organizational structure will be the number of offices reporting directly into the immediate office of the director. The first thing I will mention may be of particular interest to you. We are creating an Office of Public Health Data Science, data surveillance and technology reporting to the director as we continue to move forward our all-of-agency data modernization initiative and bring the data infrastructure necessary to connect all levels of public health with the critical data needed for action. Data functions from C-cells will move into this new office, and NCHS Health Statistics will report to the director of this new office. We're also creating a new Office of Health Equity reporting to the director to help us weave equity into all the work that we do across CDC and improve accountability of our shared equity goals. And the Office of Science and the Office of Laboratory Science and Safety will now report directly into the immediate office of the director. The MMWR and the Community Guide will move into the Office of Science. So speaking about changes for our laboratories in particular, we are elevating the Office of Laboratory Science to report to the director, and that will immediately improve accountability for delivering timely information. The functions that support all CDC labs, quality management, regulatory oversight, safety training, as well as support to state and local labs across currently in OLSS, DDID, and DLS are all being centralized into this Office of Laboratory Sciences. And after the new structures are in place, I am empowering the CIO leaders, such as Jim Perkle and Laboratory, to move forward on other organizational changes within their own CIOs. The Office of the Associate Director of Policy and Strategy will be renamed. This will now be the Office of Policy Performance and Evaluation, still reporting into the Office of the Director, and that office will now include regulatory affairs. And the Center for Preparedness and Response will be renamed the Office of Readiness and Response and report to the Office of the Director, creating a centralized office to promote accountability and excellence for all readiness and response efforts. Our new Center for Forecasting and Outbreak Analytics will report to the director of this new Office of Readiness and Response. We are doing some consolidation. We are consolidating the public health infrastructure and workforce activities of CSELs and CSTILTs into a new National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce. This new center will combine the critical functions related to supporting state, tribal, local, and territorial public health infrastructure and workforce. And as Deb mentioned, CDC awarded its first of its kind $3 billion grant to provide the people, services, and systems needed to promote and protect health in U.S. communities. This new proposed center will centralize CDC's activities to further accelerate this work. We will have a new global health center, and that will consolidate the work of the global health coordinating unit that included our regional platforms, as well as the Center for Global Health. I'm pleased to say that Dr. Howard Zucker joined CDC in January in a new position as this agency's Deputy Director for Global Health, with broad operating authority, responsible for overall planning, direction, and management of CDC's global strategy, both here in the United States and around the world. And this position will have day-to-day oversight of our Global Health Center and will also work directly with our global health programs across all of CDC. We have a new leadership position. The Director of External Affairs will be created in the Office of the Chief of Staff to strengthen our relationships across government, academia, and nonprofits, as well as the business community, and helping outside organizations navigate and partner with CDC. As you can see, we are doing far more than moving boxes. I call that necessary, but not sufficient. We are addressing longstanding agency-wide challenges, which will require change across all of CDC, from structure to processes to operations. So in addition to the organizational changes, we are improving our systems and processes at CDC. In January, we began, and now in February, we are continuing our process improvement and implementation. Because we know reorganization, moving boxes alone, will not improve our processes, we also convened 21 priority action teams to offer process improvement solutions. These teams included more than 160 staff from across the agency and provided input in 5 key areas. How do we share our science and data faster? How do we translate that science into implementable practice? How do we prioritize our public health communications? Develop a CDC workforce that is ready to respond to future public health threats, and promote result-based partnerships. So that is the action of our 21 priority action teams, and a lot of work ahead in implementing the advice of those priority action teams. I want to thank you for working with us as we make our agency stronger and better positioned to deliver our public health mission now and in the future. And before I turn the meeting back to David Fleming, let me thank him for his leadership of the ACD, and again, thank each of you for your extraordinary participation in the work groups and full meetings, and for your ongoing support. I'm always grateful for your wise counsel and your proposal to CDC on key topics, and for any wisdom you're willing and able to share. So David, I look forward to hearing from the committee, and happy to pass it back to you. Thank you.
Well, thanks. You and CDC have been busy. My goodness. Sounds like a lot of great changes. I'm going to go ahead and open it up to the committee for comments. And I see first Lynn Goldman. Lynn, you're on.
Hi there. Great to see you, Rochelle, and thank you so much for all the work that you're doing on behalf of the people of this country. It is really impressive. As you were walking through all of those changes, I felt like I was watching a ball game that I don't understand, in a cricket maybe, I don't know. But it would be really helpful at some point for us to see I mean, maybe in a diagram or something, these changes that you have already made, because I do think some of the work that we're doing does involve looking at the structure of the agency, and it would just be great to be able to catch up with exactly where we are. I tried to keep notes, but I'm pretty sure I didn't follow all that. But it's obviously a lot of really good work, and we appreciate it. Thank you.
Yeah, so let me just reflect and say I appreciate where you're coming from, because coming into CDC from the outside, which is part of the reason it took us took me some time to really understand what we were working with and the pros and cons of the structure that we had, and really hear from the strike teams as to where we should be going. I think you may in your packet have a before and after flow chart, but what I will just generally say is in the before flow chart, there is this layer of offices called the communities of practice. We are generally moving away from that extra layer. Part of that is because it didn't offer a full visibility, full line of sight, as well as accountability, reporting into the immediate office of the director. And then also, if you sort of look at how that is built, it created silos between our infectious side of the house and our non-infectious side of the house. And I really felt like those silos were not productive, because we really would like them working more closely together. And if anything, COVID showed us that in spades. So we are moving away from that structure of communities of practice. The other sort of big picture thing that I can say is that we have raised up our foundational public health key areas, our laboratory, our equity, our workforce, our data, so that those key foundational areas are really front and center in reporting into the immediate office of the director. They are an important office of science, office of equity. They are really important areas that I really wanted to highlight. So those are kind of if you sort of get stuck in acronyms and lands that you don't necessarily understand every center, where the acronyms for each center, what I will say that's the sort of the big picture areas that we worked towards.
Thank you, Rochelle. And we did get the moving forward briefing. So if it's all in there, then we're good. Thank you.
Yeah, thanks. And one of the things as we move on, we're going to have to do is with all of the new organizations, very quickly, they will become acronyms with a pronunciation associated with them. So as that moves forward, please help us as CDC starts to use the new acronyms of giving us a little cheat sheet early on so that we know what you're talking about. Daniel.
And our website will be updated at the end of February with all of these changes.
Oh, perfect.
All right, thank you so much. And Dr. Walensky, thank you as well for the insightful update. I always look forward to hearing the exciting things that you've been leading. And of course, very grateful to you for your continued commitment and leadership on health equity. I was hoping that perhaps we could get some more insight, on what power and resources will be given to the Office of Health Equity moving forward.
Yeah, what I can say here is this was one area that I hope you all recognize was one I did not wait for moving forward on. It was an announcement we made, I think, weeks or just after I started. So this was one area where we had done a lot of work already in developing our core equity infrastructure and getting, I think, 160 proposals on how we can make equity front and center. Part of the reorganization was to move that Office of Equity into reporting into the immediate office of the director. But all of that hard work has been ongoing really since I started. There are areas where I want to strike a balance, where I don't necessarily want to have all equity efforts only in the Office of Equity, because I really actually think they need to be integrated into everything we do. We can't have just an Office of Equity that feels responsible. Every piece of this agency needs to be responsible and focused on health equity. But in terms of best practices for NOFOs and how we can prioritize the equity work that we are doing, how we can engage in those best practices, what's the latest science, and that's, I think, really important in the Office of Health Equity. And we will be posting a position, the lead of that office, coming soon.
Great, thank you. Monica.
Yes, thanks, David, and thank you, Dr. Walensky, for walking us through the updates about the plans around the reorg. I was wondering, in the slide deck that was shared, there was a general timeline in terms of the activities that you recapped for us, and wondering if you could say more about the different strike teams, the process improvement activities. It said in the timeline January, February, and then a reference to an executive committee or an enterprise-wide kickoff. Can you say a little bit more about the activities across those 5 areas, just general process timeline, to give us a better sense of the dates or key kind of milestones in the calendar this year?
Yes. So maybe I'll start with the organizational pieces. Those organizational pieces are I anticipate that by the end of this month, we will be fully functioning in this new organizational structure. Now, what we have said, and I think is really important, is under this new organizational structure, there may be further organizational things that need to happen at the center level. And so we have asked individual centers to do that work now. This was going to be the one sort of centralized piece, but we wanted to, we understand in sort of CDC moving forward that to accomplish those structural missions, people within, or those process and procedure missions, people within the centers may have other changes that they'd like to make. So those are currently ongoing right now. Within the centers, they're doing that evaluative work right now. So that is really sort of what's happening at the structural level. The priority action teams, those 21 priority action teams and the 5 priorities we talked about, developing science faster, developing implementation guidance, communications, partnerships, all of that. There have been lots of recommendations from each of those priority action teams. So what we've had in those 21 teams is them talk about what are the most important things that we need to do. We can't do everything all at once, but what are the most important, even if they're hard, even if they're going to take time, what are the most important things that that need to be done? Some of those we need to just do immediately, and some of them are going to take some time. And so each of them, and some of them are going to be ongoing activities. These are some of the differences in how we have to work. But what I will say is that, for example, in the communications area, one of the things that we really wanted to do was look at our website. People now, Americans are now coming to our website in ways that they hadn't before. And when I arrived, I believe we had about 200,000 web pages of content on the CDC website. So we are doing a project called Clean Slate, where we are looking at our website, all of our components of our website, seeing what needs to be archived, what can be archived, what is not yet, what is not in plain language and accessible. And that is work that's probably going to take close to a year. So it depends on sort of what the activity is in all of those priority action teams. Some of the partnership stuff we can do outreach quickly, but some of these other things are going to be truly heavy lifts.
Thanks. Josh.
Thanks. Hi, Dr. Walensky. Thanks so much for the presentation. Thank you for this hard work in rethinking the agency. It's really like a back to basics reorganization, really making sure that these, foundational areas are strong across the agency. A really important move for labs, which is, great to see. We'll be talking about that more later today, but just wanted to really appreciate your understanding of the fact that CDC is a lab agency, in addition to other things, and it really has to do that well. It's really, really terrific. I had a question. One of the things through the pandemic that's become obvious is that the CDC is challenged by the sea of misinformation out there in ways that your predecessors really were not, and your preceding versions of the CDC org chart were not. And it's, it just continues to, amaze the kinds of things that take off and people tend to believe. And even almost everything that the CDC releases gets distorted in some way and fed back into this information morass in a way that can really be undermining people's ability to know what's right. And that also impairs, I think, on the political side, the ability of people to support CDC if their constituents are being fed a steady diet of falsehoods, frankly, in many cases, not just about COVID, but about vaccines and other kinds of activities. And I wonder whether you think the organizational structure or the way you think about the change is like, adapting to that reality. How do you see the ability of the CDC to understand, respond, build bridges, to get over the river of misinformation? How does that fit into the organizational restructuring?
Well, so first of all, this is something that is deeply concerning to me, obviously, for all of the reasons that you comment on. We have a lot of work to do on our communications side. One of the real challenges, I think, and our Office of Communications always fed into the Office of the Director. We have a lot of work to do in bolstering that and reorganizing that office specifically, and that work is actually underway, not just on the website, but just in terms of do we have the right structure of divisions and branches that are happening within that office specifically. If you look at where we are in terms of the resources that we have in communications, and our communications resources have not scaled with the resources that have been provided to the agency through this pandemic or otherwise. And so I don't necessarily think that we at CDC alone we need to, and we are addressing misinformation. But if people are challenging government information to begin with, then we alone are not going to be able to tackle that. So we are doing a lot of work to try and get at and working with other outside groups to get at what are the sources of that information. Can we cut it off as it's starting to blossom? And what is our role in that misinformation? So, for example, there have been, and we've had discussions. What is when there is a tragedy of a public figure, and the next thing is it's due to the vaccine. What is our role in that? And that may take off, but I'm not certain that we have a role in being able to. We don't necessarily know the cause of whatever the issue was. Likely not the vaccine, but what is our role in response there? So we have had a lot of conversations. We have more conversations to be had. I think that this is an agency-wide effort. It has to be a whole of USG effort, and then I think it also has to be an academic and industry effort as well.
Yeah, thanks, Josh, for raising that. I'm doing a little bit of work with communications at the state and local level, and I think the issue around misinformation, when you talk with state and local communicators, rises to the top of their list as well. And so, as we're trying to devise a way forward, please work with them as well. Julie, good to see you. I mentioned to folks you were going to be a minute or two late, so please ask your question, but if you could just quickly declare any conflicts of interest first, that would be great.
Sure. Thanks, folks. Hi, Julie Morita here, and I have no conflicts to disclose. Hi, Dr. Walensky. Nice to see you. Thank you so much for all the work that you've been doing and for the progress that you've made. I have a kind of a general organizational structure question and then a more specific question related to data. The organizational structure makes me nervous for you because I look at all the spokes coming off of your office and the responsibility that you have to them. And one of the things I was wondering about as you talked about the siloing that we see happening within, it's in all organizations on a smaller scale at RWJF, but at a much larger scale for you, there's this siloing that we see happening. And just wondering if you're envisioning that these offices that report directly to you will actually have any kind of authority over the centers or the institutes that report up to you as well, because I feel like in order for it to help eliminate some of this siloing that occurs, if you look at equity or you look at laboratory, you look at health data and surveillance and technology, these are cross-cutting kind of functions. Do they have any authority over the centers? Because unless there is some kind of authority, I would think that this siloing could continue to be a problem. So that's question number one. And then the second question I have is just related to Office of Public Health Data, Surveillance and Technology. Just curious if you could elaborate on what that means to the Data Modernization Initiative, because I think there's a lot of we were all working toward that, aware of what was happening, and just wondering how the restructuring changes or doesn't change that effort.
So maybe I'll tackle the first one first, or the second one first, which I think is easy. That is the data modernization effort. So all of that is being centralized into one place. And in fact, that'll then speak to the second issue, which is it's not lost on me that there are a lot of spokes coming in on that in the office of the director. And so what we've been doing in the office to facilitate that is, you may or may not be aware that our current immediate office of the director, even our immediate office of the director of 6 months ago, was a really tiny team. And so what I have done is bolstered that team. So I have deputy director of program and science, so that'll be Dr. Howery. We have a global deputy director. We have a principal deputy director. So we're bolstering that team. A policy comms and ledge deputy director. We're bolstering that team so that I have a bigger, mightier team around me to help facilitate that. Now, one of the questions that you asked, I think, is a really important one, which is how does the infrastructure weave into the centers? So it's really important to me from a DMI standpoint that all of the centers are on board for the data modernization piece. If anything, I would like to say that infrastructure is more important because we need to be able to have all of that, and there's nothing, not more or less, but we need to have it all together. Similarly, for our readiness and response program, we need to have an infrastructure that allows people to be ready to respond, and those responders may have to come from the centers, right? So that is part of the work of this governance board, this executive governance board, which will overall take the agency's needs, putting aside from wherever you came, to say, what does public health need? What does CDC need in the moment? Let's check our own interests at the side to say, and that'll be a rotating board of people from everywhere to say, I recognize that this data modernization effort may pause your data collection in the center until we get it up, or may put you a little bit behind, or you may not get that singular piece that you wanted. But for the purposes of streamlining data, standardizing data collection, making it easier on all of the stilts to be able to provide data at large, we need to do this. And that's actually the work, a lot of the work of that governance board too.
Thanks. Rhonda.
So, Director, much appreciation and no questions for you, just a comment. Thank you very much for continuing to work through what is difficult in the quietest of times, but even more challenging when there's so many who have so many opinions. I just wanted to just say that I appreciate the parts that you have elevated and brought in closer to you, the intentionality behind it. About why you did these things and the way that you're approaching them, and then the acknowledgement that there's going to be more to come. So just a deep thank you. You need to hear that, everyone.
Thank you very, very much. I'm grateful for that. Not everybody's comments are like that all the time, so I'm grateful for that.
Thanks, Rhonda. Well said. Lynn.
Yes, Rochelle, I just had well, one, I really did want to second the point that that Josh Sharfstein raised, and I'm happy to hear that you are intent on bringing more sophistication into CDC's communication efforts. It's something that we all have to do in public health. Everybody has to do this, and because public health has become a target by many. And we're not going to fix that by just controlling the communications more, or, I mean, in some ways, as a former government employee myself, I worry about elevating all of the communications functions, because to some extent, the trust, in the government is fostered by people being able to hear from the experts in the government, the people who really know what they're talking about, even if they sometimes don't understand all the words. Sometimes it does come through. Those folks know what they're doing, and that's very important for trust. The other thing I wanted to bring up so often, and I'm happy as you just heard, I agree, the intentionality behind the changes you've been making in the structure is wonderful. And at the same time, where we put people in an organization doesn't always fix many of the problems in an organization. The fact that some of the issues that CDC have had to do with siloing, and you're right, there's been too much siloing between communicable and non-communicable diseases, as if though those are two completely different things, which they're not. And yet the temptation is, well, let's create another silo. And the problem with siloing isn't always the org chart. It's the way people do or do not work well in teams across an organization. And any organization like yours needs a lot of that teamwork that is cross-cutting. And it's also what motivates people in an organization. What is the definition of success? Is success, am I successful only because I have more people and a bigger budget? Then I'm going to fight for that. And I won't care about the health and the well-being of the rest of the organization. I will fight for a bigger budget and more people. That's what people often do in any kind of organization, corporate, government, whatever. Is the success, if I'm a scientist, I'm not going to be recognized as a scientist. I'm only successful if I turn myself into a manager. I might not be a good manager. I'm trained to be a scientist. But if success is defined as I have to manage, or I can't get, that promotion, I don't get any recognition, then I will try to turn myself, and I see that again and again, especially in the government, other than NIH, that people who are fabulous scientists abandon their science, they can become an administrator and be recognized for that. And, and a success only identified as an individual's own accomplishments, or is a team recognized for what they do. And because if I want to be recognized as an individual, I may not be a good team player, and if teams are recognized, it's possible to foster that. And which means I think that it's not just the org chart, but, the part of your office that has to do with management, getting, really strengthening just like with communications, the savvy and the capacity of those folks to help to realign the expectations, the motivations, because you can reorganize and then you just create new silos and you have the same problems with dysfunction. And
Lynn, I think you're spot on, and it is why we needed to do the strike team work in parallel with the priority action team work, where the strike team work was really speaking to what's the organizational structure that will allow us to operate in our maximum capacity. And when we do that, what are all the other things that we need to do to operate at our maximum capacity? So I always think that people come to work because they feel valued. And if your science is feeling valued because you can get it into a peer-reviewed publication, then that's great. And if we at CDC are both a science-based agency and a lab-based agency, as Josh noted, and a response-based agency, how do we make sure that people are feeling valued in their response-based work? Part of it is, are they good at it? Have we trained them to do that work? Do they know what they need to do? And that is everybody who books the overnight flights, to the person who does the logistics, to the person who is out in the field, to the person who's doing the VE studies. How do those people feel trained in what they do, and how do they feel valued? How do we promote them for their response-based work? And that's a lot of the work of having a CDC workforce that is ready to respond. It is how we are organizing our performance metrics, where they're no longer going to be, they will somewhat be based on the science you put forward, but also be based on the work you're able and willing and wanting to do and trained to do in responses. So that's one example of some of these changes that we need to make, that people need to be valued for many of their other things. And as I make these calls to folks who I call my unsung heroes, and just call them and say, thanks for the work you did. It didn't necessarily make the byline of a publication, but I saw you in that work. And people routinely say it's like super fulfilling. They didn't necessarily realize how fulfilling it would be to work in a response. And so that's some of the work that we're working to do.
Thanks for your efforts there. Wow. Crystal.
Yeah, thank you. Hi, Dr. Walensky. I'm switching topics a little bit, but I wanted to go back and revisit something that we've talked about, a challenge that we've talked about in previous meetings, which is the disconnect or the misunderstanding that many people have about, the authorities that CDC, actually has. So there's, kind of an expectation of what CDC does or what people think CDC should do. And then there's, the lack of authority that you may have to actually do those things. And I know that you've had conversations on the Hill in recent months and, elsewhere, about that, doing education about that, advocacy around it. I just wanted to see if you might be able to speak to, to that a little bit, is how is that educational process going? The answer may not always be to have more authority, but, just advancing that understanding of, if you want CDC to do X, then why, then this is what would be needed in order to accomplish that.
Thank you for that, Crystal. There are, so I have frequently said we are going to do everything that we can at CDC to bolster our public health infrastructure at CDC and around the country, and that is laboratory, workforce, data, and equity. And we are going to do the work of CDC moving forward within the agency. But there is this critically important pillar that you note, and that is the things that we can't do, that we need congressional help and support to do. And maybe I would put them in probably 4 buckets. There are probably more, but 4 big buckets. One related to our data authorities. We receive data currently in a non-standardized fashion that is voluntarily reported. I still don't know who is vaccinated in hospitals, and that is with a public health emergency in place. We are not confident that we will get immunization data from every state at the end of a public health emergency. We're working through that now, and that is with COVID. And so when you get a sense of all the other data that it took us 2 to 3 months to work out data use agreements on getting vaccination data for the Jynneos vaccine. When you're in the precipice of a public health emergency, you really don't want to be in that position to try and be working on data use agreements. So again, to be very clear, we want to have it privacy protected. We are looking to do this from a public health vantage point, and not just at CDC. We want you to know the neighboring counties, so you know what is happening around you as well. So county to county across the states, state to state, standardize that data reporting and have it accessible so people know what's happening. So data authorities is one. Human resources authorities is another. The capacity, if we are a response-based agency, what does a response-based like FEMA have? What does that look like? I will tell you, I had some incredible team members who went in the thick of the Mubende, Uganda Ebola outbreak. They did not receive hazard pay. Our work did not receive overtime pay. So as we don't have tax deductions for loan repayments. So as we think about those kinds of human resource authorities that if we are intended to be a large scale response-based agency, we need to have. The third is Paperwork Reduction Act, which we actively work under, that does not allow us to get to do studies or collect data necessarily in real time. We've been exempt for some of that during COVID, but during the, we quickly were able to funnel passengers to do screening during Ebola for people who are coming from Uganda, but we were not able to get the survey to receive the data from the states. That just gives you an example. If there were an environmental hazard, a spill, or an environmental toxin, it could take us months for us to be able to get an approved survey for the potential damage that was done. And that would be obsolete at that time. So the third would be Paperwork Reduction Act. And then finally, and another one that I think is really critically important, is we don't have capacity in this country for vaccines for adults. We have a Vaccines for Children's program. It's saved over 1 million infections and deaths in children. It's saved trillions of dollars since it's started in 1994. We do not have a comparative program in adults. It is probably the reason that we get 50 to 60% of adult vaccination for influenza every year. We are working towards what's going to happen with the COVID vaccination and working towards efforts there. But about 20% of adults over the age of 19 have received every vaccine that they should. And we have, under and uninsured adults who don't have access to vaccination. So those would be the 4 big buckets in my wish list.
Thanks for laying those out. They're critically important. Our job on the committee is to advise you, but please know, just in talking with committee members, if there is work that we can help with in educating others about these needs, we are on your side, because you are absolutely correct, and just, feel free to involve us and let us know. We have a few more minutes left. I'm going to ask one question while I wait to see if anybody has a final question. And it has to do with the work that you're doing, which is great, to think about ways to break down the silos at CDC. And many of the new units you've created in the Office of the Director are designed to do that. My experience has been that the centers are working full steam, often underfunded, on their priorities, and working across centers on some of these issues like equity and data takes more work. It needs to happen, but it does take more work. So I'm wondering how you're thinking about and advising your center directors for the increase in workload that they're about to inherit as a result of the reorganization and the need to begin to work in a more, I'll say, integrated way across the agency. That's gonna take time and energy at the center level as well.
What I'll say, certainly everybody in CDC is not like-minded on this issue, but what I will say is there's active energy to want to improve. There's active energy to want to be better, and people are motivated by some of these missions and goals in ways that, I haven't been there for longer than 2 years, but ways I'm hearing that haven't happened before. So certainly there's a diversity of opinions there. What I can tell you is in areas where there have been, there's a long menu of things, of areas to improve. I've asked people to prioritize. I've asked people to strategize. I've asked people to say, maybe you don't need to own that one alone. Maybe you can own that with a center, is a different center. It's also the case that I do think people are energized by the cross-cutting work. When we have had people engage in work across social determinants of health, there has been, people are motivated. The equity work that we did to create the core infrastructure, that was April of 2021 when we launched that. And the agency was tired. This was knee deep in the middle of COVID responses, and people were motivated and energized. So I do think it was really, it's really an important, when people are committed to it, they're willing to put some time and energy in that place, even if it's sort of the extra time and energy that they otherwise didn't have. They find value and import in that work. And maybe I will just, I will say, just in response to the prior comment that you had, David, if I might, is from perches that I've had prior to my being here, the authorities that Crystal allowed me to raise were not obvious to me. I do think that people do not recognize ways in which our hands are tied to deliver on things that they expect from us. And so you're helping to send those messages to your academic circles, your political circles, your to say, like, I would love to deliver and be very transparent in the data we have. We don't have authority to get it. And so I would really, really welcome your outreach on those areas, because even, in the best of academic places, I don't necessarily think those are obvious to people sitting in those seats.
Good point, and we will do. Time for 2 last quick questions, Octavio and Jill, and then we're going to move on. But Octavio, please.
Thank you, David. Thank you, Dr. Lansky. Octavia here. Great to see you. And you've covered a lot of ground, which is fantastic. Been listening intently. One area that you haven't covered, I'm really interested in, is because the CDC has for such a long time been seen as a gold standard. But on the international scene, how do you feel your relationships are? And what are you sort of prioritizing as from outside of the US and working with our other public health partners out there around the world?
I think our global mission is key and critical, and it's among the reasons we have a new deputy director in place. I love traveling internationally because we are perceived as that gold standard. When there is a new public health agency that is developed in a different country, they often come and look to CDC for what we are doing. I am hearing in our ministry meetings that in our international meetings that meetings do not start without CDC at the table. I think when you look at some of the responses that have occurred, and there are a lot of responses happening across the world right now, our ability to do the field epidemiology training programs, to launch those programs and to create, the whole goal, of course, is that we'd love to put our public health self out of jobs in those countries because, in fact, we have done the training necessary, the laboratory, the surveillance, all that is necessary so that they can be sustained. And I do think in those countries, and what I do think we saw happen because of that integrative work that we do, and I'll maybe just call on the Ebola outbreak as one, is trusted people on the ground, trained people who then, I think all of the FETP graduates from Uganda were working in the Ebola response. It's exactly what you want to see. So I personally think that our global work is probably the most unappreciated, incredible jewel that we have in this agency. And so we're doing work in Kyiv right now and reestablishing our office in Kyiv. It's really, I think, underappreciated domestically.
Perhaps at a future meeting, we could have a session on global health. I think many of us on the committee would be interested in that.
That would be great.
Joe, last question.
Dr. Walensky, it was good to see you last week, and thank you for all you're doing. So the last thing the world needs at the moment is another pandemic. But as I read ProMed every day and see isolation on detection of avian influenza, moving into the mink population in Spain, to put another pressure on CDC, we need to be ready for that. And I'm particularly motivated to talk about the laboratory response network. It did not play a role during the pandemic. It really needs to. And so I apologize for raising one more problem, but I think that the LRN is just essential in any response of that potential magnitude, and just want you to keep it on your radar, please.
High on my radar. We've already been in touch with our teams as to where we are with both surveillance and detection, as well as our USDA colleagues in the detection in the avian population as well. In fact, I know I have a hearing tomorrow and a briefing the next day on exactly that issue.
Thank you.
Well, we've run a few minutes over time. Thank you very much for staying with us, and thanks for this update. I hope you can feel both the energy as you've created and the support of this committee and the work that you've done. We will be willing, ready and waiting to continue to provide advice, because as you've said, this is the first big step forward, but there's additional steps that you're going to need to be taking. So thanks very much.
Great. Thank you all very much.
Yeah.
Thank you all, everyone.
Great. Wow. Julie, you're going to have a tough act to follow here, but we're going to move on the agenda now to hear our report from our data and surveillance work group. Julie, I'm going to, you need no introduction, so I'm going to ask you to go ahead and take the floor. Nirav is going to be joining us a little bit later, but I think you're doing this solo on behalf of both of you.
Yeah, thanks so much, David. And you're right, it's a tough act to follow, but everybody is clearly wide awake. So I think that gives me an advantage. So thanks, everybody. So I have the honor of giving the data and surveillance work group update on behalf of Nirav, who has a conflict this morning, but will be joining us later today, and also the incredible working group members. And I think some of them actually tuned in to listen to today's meeting as well. So I'm glad to be able to do this and look forward to sharing our progress and then also hearing your feedback as well. Next slide, please. So what I wanted to do before jumping into giving you an update on what we've done since we last met, I wanted to update you on what happened to the ACD recommendations that we all submitted to HHS. They were approved and accepted by HHS, so that's exciting to hear. And I just as a reminder, so you all remember what it is that we all approved last time we met, was that there were 3 priority areas to improve essential data exchange between healthcare and public health systems. And the first was really focused on defining the minimal data necessary for core public health data sources. The second was to establish public health data system standards and certification. And the third was really, as it relates to, as Dr. Walensky mentioned earlier, how there are limitations in terms of the authorities that CDC has. We made a recommendation regarding establishing data use agreements and frameworks that could be put in place, even though there isn't a whole lot of authority that CDC actually has. Next slide, please. So just to get a little bit deeper into each of the recommendations, I thought I would just provide you with a little bit more detail about each one of them. And then I'll ask Jen Layden, I think who's joined us as well, to give a little update on what happens next. But first, in terms of defining the minimal data necessary for core public health data sources, it was really, our recommendation is for CDC in consultation with the state, tribal, local, and territorial partners, and with input from healthcare and federal agency partners, that they should actually develop and regularly update a list of data elements that constitute the minimal data necessary for disclosure to CDC for public health activities. And then also, there was a follow-up recommendation to work with STILTs to develop a list of data elements that would be reportable to the STILTs as well. So it didn't just stop at the CDC level, but it went on to the state, local, tribal, territorial level as well. Next slide, please. The second was really establishing public health data system standards and certification. So the recommendation was for CDC in collaboration with STILT partners and the Office of the National Coordinator for Health Information Technology, or ONC, and that they should develop and implement a coordinated phased approach to certification, which to start with expanded guidance for public health criteria, move to requirements, and ultimately advance to certification. So as has been done for healthcare system, public electronic health record systems, this is a certification process that would be done for public health data systems as well. Next slide. And then the third was to establish data use agreements and frameworks, recognizing that CDC doesn't necessarily have the authority that they need. The feeling was that CDC, in coordination with STILT partners, could actually establish a proactive approach for data use agreements and to streamline the process. So really looking at umbrella kind of an approach that would standardize language, provide standardized language for core components of data use agreements to address the common challenges. And then looking at ways to leverage sharing data expectations through federal funds, through some of the assistance mechanisms like grants and cooperative agreement. So that's what the third recommendation actually entailed. And so at this point, what I'll do is maybe open it up for Jen Layden just to give us an update from a CDC perspective and what, now that these recommendations have been approved by HHS, what happens next. So Jen.
Yeah, thanks, Julie. And thanks for the opportunity to join the ACD for this presentation. Really excited to see the both the endorsement as well as the approval by HHS for these recommendations. I think these were felt to be really strong and important steps that we take to promote the sharing and exchange of data across the public health ecosystem. Now that the approval is in place, the next steps are to really lay out an implementation plan. Very excited to move forward with this. There is some ongoing work already that is occurring around minimal data sets, particularly for case data, both as part of the case surveillance system, as well as thinking it from a response standpoint. In doing this, we will need to work very closely with our partners, state and local partners, to develop some of the language and get to consensus on some of these critical aspects around DUAs, as well as the minimal data necessary, and identify some of the challenges and barriers as we lay out a implementation plan for standards and certification. So a lot of work to come, both within CDC to bring the team together for these 3 recommendations, but also doing it really closely with our partners. Thanks, Julie.
Thanks, Jen. Yeah, thanks so much. I guess for those of you who don't know, Jen was asked to be the interim, is it director, interim lead for the Office of Public Health Data Surveillance that reports directly to the director's office. So thanks for your ongoing support, Jen.
Absolutely. Thanks, Joyce.
Next slide, please. So now I wanted to switch toward talking about what we've done, what the Data Surveillance Working Group has done recently since we last met. One of the areas in our terms of reference that was of great interest to the group itself was really data science and information technology workforce. And the other was something that emerged kind of as an outcropping of the conversations that we're having related to workforce related to sustained funding challenges. Next slide. So what we did, the working group did in the beginning was really to get a presentation from Dr. Patty Simone, Director of Scientific Education and Professional Development at CDC, to understand some of the challenges that they're experiencing. And what she identified were really a couple of categories of challenges that were really significant, including workforce shortages, which I think is not news to any of us. And then also, in addition to workforce shortages, a problem with needing increased needs for our workforce training, that the current supports and training that are available are inadequate to really keep up with the times and keep up with the technical needs that our staff actually need. The second category, second thing was we did with this group was really inquiry our data and surveillance working group members to get a sense of what their priorities were. And what was interesting to see is that the priorities that arose from the group were really focusing on state, territorial, local, and tribal workforce needs, and then also really taking advantage of leveraging academics and private sector. So these are the areas that emerged from our working group members themselves. Next slide, please. So as we talked about the workforce itself, what we recognize is we have some needs that we really need to get it to address from a work group perspective. In terms of workforce shortages, we really need to quantify the staffing needs. We have a sense that there's enormous needs, but we really haven't quantified by category or by need what it actually looks like. We also have a sense that there's an opportunity to supplement workers with partnerships with private sector, academia, and healthcare. And so there's opportunities there. We just need to understand those a little bit better. And then also have to, in that context, better understand what the public sector's capabilities are versus what's best suited for academia, healthcare, and private sector, recognizing that if there is a role for them to play, then what is primarily the public sector's responsibility and capability, and also what is best suited for the other partners. In terms of workforce training needs, we also have identified that there's a need to define what competencies are necessary. So we say that this workforce is inadequately trained and needs to be upskilled, but we haven't really defined what those competencies are. And then also that while there are training programs that are existing, they really need to be enhanced for both our future workers as well as our existing workers. And then acknowledging is again that in addition to addressing workforce shortages, partnerships with private sector, academia, and healthcare could actually help to address some of the workforce training needs as well. So there's opportunities there. So in terms of next steps for the working group, we don't have areas of focus to bring to the ACD today for consideration or for voting, but really we will be delving into these issues that have arisen and identifying which priorities we would want to bring forward to you in the coming meetings. So just wanted to give you a sense of what we're thinking about and where we're heading at this point. Next slide, please. And then what emerged from our conversations related to workforce was a lot of concern about sustained funding challenges. That there's concern about the current levels of funding, given the enormous needs that there are for really shoring up the data science and information technology workforce. We need to really have, while funds have been made available, they're not necessarily sufficient to meet the needs of states, locals, or at the federal level. And then also, in addition to that, some of what's hampering the ability to use these funds are the anticipated funding cliff. That although there may be a lot of money out in the system right now, we know that it's very time limited, and there's concerns about how much you can really invest in a workforce if you know that funding isn't going to be sustained for the long term. So that's a topic that we just started delving into. And so what we've done more than anything else is really identify what we need to better understand. And so we need to better understand existing funding. We want to understand funding approaches for enterprise services and resources, for example, cloud services. And then also understand the challenges that are being experienced by our state, tribal, local, and territorial partners. And also understand what other federal agencies or other sector models have for sustainability. And I think we heard Dr. Walensky mention that how some of the other federal agencies have greater authorities or greater abilities for lots of different things. CDC has some limitations. And so looking at other sectors for models of sustainability may be helpful as well. In terms of next steps for this sustained funding challenge that we've identified, is we anticipate asking for an update on the infrastructure grant, which I think we'll be hearing shortly in the next session from the Centers for Surveillance, Epidemiology, and Laboratory Services. And then we also want to have a better understanding about the epidemiology laboratory capacity grant that is given on a regular basis to get a sense of how that fits in with some of the infrastructure funding as well. And then lastly, and not necessarily lastly, but last on our list for right now, is really understanding the funding challenges that by hearing from ASTO, CSTE, NACHO, HIMSS as well, so we can better understand what the funding challenges are themselves. So I will stop there and just pause so that we can actually hear your thoughts or reactions to what I've shared with you today. And really, again, appreciate having the opportunity to share this update with you all today.
Great. Thanks so much, Julie, for that great presentation. And thanks, Jen, also for updating us on the recommendations and where you stand with moving those forward. We'll go ahead and open up to the committee for questions for either Julie or Jen on the presentation, the path forward for CDC and the path forward for the data and surveillance work group. So the floor is open. While people are thinking, let me ask one. I'm fortunate to be able to participate in the work group, and it, as Julie said, it is concerning when you look at the amount of financing that's available, how long it's available for, and what needs to happen. There does seem to be this potential gap. I think everyone would agree that we're a long ways behind where we need to be, and that the financing that's currently available will only get us partway there. I'm wondering from your point, Julie or Jen, whether or not there's any recommendations that might need to be made on prioritization, on saying, okay, given that we are in a place where we need to get some things done, but we're not able to do everything, how we might think about what needs to happen first.
Yeah, I mean, I think that makes I'll start, but Jen, please jump in. From my perspective, I think like that's a critical thing that we need to be thinking about, because when you are in a situation with inadequate resources and you really do have to prioritize, I think one of the things that we've listed as a next step for us is, or maybe not even for us, but really as a recommendation to CDC, is to consider really quantifying what the need actually is. Because if you can quantify it and then categorize it, then you can say, oh, well, in these categories, there's clearly a need and we need to prioritize it. But at this point, it's really difficult to do that. We don't at the work group level, don't have insight into that itself. And I don't know that that's our decision to make as much as a recommendation to really understand what is available, what the deficiencies are, and then to prioritize based on what we see. But Jen, please feel free to jump in.
Yeah, thanks for flagging and raising that, David, and your answer, Julie. So yeah, there's been some really good estimates both by CSTE and HIMSS on the cost of DMI modernization, and the costs that are projected are much higher than certainly funds that are available. There's continued effort to continue to update those to be as consistent or reflect the reality of the situation. We do hear, I would say quite often, from states and locals, the concern of investing in something, not knowing their ability to sustain that long term. So that is a challenge that we hear and recognize to be a real challenge for states and locals and at the federal level. For CDC, as we are standing up the proposed new Office of Public Health Data, Surveillance, and Technology, one aspect of that work in function of that office is to define a public health data strategy. In doing so, one of the things that we think is critical is to outline the priority work for the next couple of years, recognizing that the funds as well as the bandwidth, as far as personnel and resources and time, don't enable us to do everything right at once. And so to really articulate from a public health response readiness and to support those core missions across public health, what do we want to prioritize for the next couple of years? As we're standing up the new office, our goal is to disseminate that and also work very closely with our partners to support the alignment on that, recognizing when we're talking about some of this core priority work in the core data systems, the exchange of the data occurs across the ecosystem. So we have to get more, we can be aligned on that, the better. so there's effort there to the sustained funding. One of the things that we need to start looking at is what that sustained funding model looks like as more and more jurisdictions are going to cloud migration. The reality of the costs are quite high, and how do we support that in a way that it enables a sustained function and not have to take a step backwards for some of the progress that has been made across the jurisdictions.
Thank you. Jill.
Thank you for that presentation, Julie. Just a short plea: when you reach out to the appropriate public health societies, could you include the APHL, please? We can certainly give you information about specific needs and quantification. So just that would be great. Thank you.
Thanks for lifting that up, Jill. Appreciate it.
Good point. Monica.
Thanks, Julie, for sharing those updates, and congratulations again on getting these recommendations approved by HHS. I had one question, just a reminder, if you could just remind us on the minimal data sets, and maybe this will come up in the development, further work on the work plans, where the discussions landed in terms of equity or social determinants of health measures as part of those minimal data sets.
Yeah, so we made a point. Thank you for pointing that out. And I have to acknowledge it was kind of, oh my gosh, we need to make sure we need to include health equity and social determinants of health. And we did include language in it. I'm trying to pull it up right now. But there was definitely an inclusion or recognition of the need to do that.
Yeah, that's actually, so it's in our report, and it was discussed by this committee when the committee approved the idea of sending the report forward to HHS. So
yeah,
in the form it went to HHS, it was included. Absolutely.
Yeah, I have the language here in front of me. It says health equity considerations such as disaggregation of data by core sociodemographic characteristics must be the center of the defining minimal data necessary. So we were able to get that included.
Okay,
and
thank you.
It wasn't a complete afterthought, but it was definitely like, oh my God, it's kind of like you have to keep health equity at the front of mind at all times in all things. And we did make a point of getting that included. So thank you for lifting that up.
Yeah, thank you. I knew we discussed it in November and we had seen it in drafts, but some time has passed. And so just wanted to make sure that it wasn't, on the cutting room floor, and that it made it the final approval.
Please
and then
continue.
I guess and then just one other question related on the workforce, and maybe this is a question for Jen. With the 2 new boxes and your interim leadership role of this new office, can you say a little bit more about how the work then gets connected with, this is in terms of, I imagine, business process improvement strike team, with the new structure for the state, tribal, local, territorial agencies?
Yeah. Absolutely. And just to maybe close the loop on the minimal data necessary, the case data effort is probably the farthest along. There's been some great work in that space and in partnership with some of our public health partners. And the work in defining the minimal data actually has pulled in some of the social determinant of health data elements that has been identified to be consistent across different diseases. So they're starting, race and ethnicity is certainly there, but as well as other data elements around social determinants of health. As far as the working with the infrastructure of Les's office, that'll be a really important and close collaboration, as we work on both commitment to resources that would go out to the infrastructure, how we align on guidance, how we align and partner on messaging and coordination around some of the DMI efforts will continue to be, a strong and growing partnership. As far as workforce goes, we recognize certainly that there's that need both within CDC, as far as upskill, training for already established present FTEs, as well as bringing in new skills and expertise, and working very closely with HRO on that. But there's also then the partnership with our state and local jurisdictions to identify best practices and mechanisms to support their efforts there.
Thanks, Monica, for those questions. Lynn.
Yeah, hi, and I'm a member of the working group. I really appreciate the presentation that Julie gave, and Jennifer, and I think one thing I think we understand. I know CDC understands this, the kind of overhaul that we want to see in how the data are identified, collected, managed, used, applied, to the public in real time. We know that that is not cost-free. We know that that is not something that can be simply absorbed within your budget or the budget of state and local entities. And so we know that, and any way that we can do this, that, if there are ways that we can do our work to help to not only identify our recommendations, but what are the words that need to be used to allow people at the policy level and others to understand why this is critically important and why this investment is for society has a good ROI. It's hard to say that, within the little silos of our agencies and the CDC, but societally, I think this is extremely important, and that message needs to come across. And the other thing I wanted to say is that, a sustainable system that might come through at the end as a result of some of the visioning that we're trying to put in this, as well as that internally in the agency you're putting into that, it's only going to happen with the injection of more resources in the intermediate time to turn the system around. In other words, I believe there's a considerable amount of activation energy that's needed in order to establish a better system that can be more workable. But at the end of the day, it's not going to be that expensive. But this is a time when, if we're not able to capture the fact that many people have recognized that this is a critical need for CDC to do this, this is the time to get those investments. And so I just wanted to say this, that not all of the shorter term investments are problematic. I think they're problematic where they are supporting core staff who are going to be needed year after year after year after year to keep systems modernized and to keep them working, but not when it comes to the investments that need to be made to transform the system. And I think we saw this as well with the electronic health records, the amount of money that has to be injected at the beginning to transform how a hospital, say, is doing its EHRs. That doesn't go on year after year after year. But, even hospitals have to inject quite a bit into their processes right at the point of transformation. And that's where you are, that's where the state and locals are. And I think one way we could be, possibly helpful, is to identify what are those costs, and if there's short-term funding, put them there. But what is the long-term funding that's going to be needed to sustain the system, as well as, something we've talked about a lot, but the kind of expertise that needs to be available at all levels, which is not in place. So thank you for that.
Thanks, Lynn, for those comments. And thanks. I think we're going to move on, but I really appreciate the presentation. Thanks, Jen, for taking the time to be here, and Julie and Nirav. We really are looking forward to the work that you're doing, and potentially an update with a report in the coming meetings. So thank you very much.
Thank you.
And Julie mentioned, and I think we did this well in the agenda planning, that one of the issues that the group is looking at is workforce issues. And so we wanted to move forward now to our next presentation. Early in the ACD career, maybe a year or so ago, we had a presentation from Patty Simone about the upcoming CDC infrastructure grant. We're now going to hear how that's been, and we're really delighted today to have Dr. Les Dauphin, who's the director of CDC's proposed National Center for State, Tribal, Local, and Territorial Public Health Infrastructure, I'm going to ask her at some point to tell us what that acronym is going to be. But she's a perfect person to be leading that center. And as we move forward, she's going to be overseeing really the management and the improvement of much of CDC scientific and infrastructure services. Dr. Dolphin's leadership, I think, goes without saying, but I'm going to say it anyway, has also been instrumental in CDC's moving forward infrastructure initiative that Dr. Walensky spoke to us earlier. Celeste, you're on, and thanks for being here.
Great, thank you. And good morning, everyone. Really delighted to be here to talk about, well, two things. I'll talk a little bit about the Public Health Infrastructure Grant Program that you requested to hear about, in which, as Dr. Fleming mentioned, Dr. Patty Simone talked about during a previous update. And then I will talk about the CDC's new National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce, which Dr. Walensky just shared as a part of her update. And David, to your question about the name, we are embracing this big name, referring to it as the Public Health Infrastructure, but it is a big name because we think this new center has a really big mission, which I'm delighted to talk to you about a bit today. And I also think that Julie's presentation was a really nice segue with the discussion about workforce shortages and needs. And I really appreciate the comment by Lynn about the topic around sustained funding. And so I'm hoping that as a part of our discussion, Lynn, we can talk about that with regard to workforce, so thank you. We are excited about the next 5 years of work and its potential for strengthening public health infrastructure. And if we could go to the next slide, I just want to share a definition that we are using when we refer to infrastructure. I think you heard Dr. Walensky mention this a bit, but I just want to be clear because we actually did a thoughtful approach in looking at some sort of many references to think about what we're really referring to here. And when we refer to infrastructure, public health infrastructure, we're referring to the people. We think our public health workforce is our most precious asset. We're referring to the services and then the systems that we need to promote and protect health in every U.S. community. And it's important when I refer to U.S. communities that I'm really clear that we are looking at, along with our 50 contiguous states, Alaska, Hawaii, our U.S. territories, freely associated states, as well as our government to government relationships with tribes, which is also indicated in the name of the center that I'll talk about. The other thing I want to highlight there is this thread through every U.S. community is really us demonstrating our focus, our strong focus on health equity in every one of the initiatives that I'll talk about here today. So before really getting to the details of the grant program, which you asked about, I thought it important to highlight some of the challenges we're really trying to face with the establishment of the new center and development of the grant program. So if we could go to the next slide, please. We all know that for decades, neglect and underinvestments in our public health infrastructure have really caused us challenges. We've existed in this cycle where we have a crisis, then there's a highlight of the weakness in the nation's public health system with these short-term investments flooding our health departments with no sustained funding to maintain the support that's needed, particularly around workforce and systems. Then experts examine the state of our public health system and highlight the need to strengthen it. We've seen this time and time again. I just highlight the 1988 HIV/AIDS challenge when an IOM committee examined the struggles and highlighted that this is going to be a challenge if we don't address our public health system. Next slide, please. And then we saw it again. One example, 2002, followed the 9/11 and anthrax, same thing, crisis, influx of funding. IOM examined the state of public health in the 21st century, and once again, noting the neglected public health infrastructure and vulnerabilities it presents for the nation's health. And then more recently, next slide, in 2022, the Senate Committee on Homeland Security and Government Affairs published a report titled Historically Unprepared on the nation's early response to the pandemic, with findings recognizing the need to support our public health system. So these are just 3 examples where we've seen this cycle of underinvestments, flood of investment during a crisis, and then identification of a need to really address the system. I did want to highlight also some others more recently and specifically related to workforce. In October 2021, referring to the De Beaumont Foundation and the Public Health National Center for Innovation, really conducted a really first of its kind analysis to estimate the number of state and local public health staff needs, and highlighted that there is a minimum of 80,000 full-time equivalents needed to be hired to provide the minimal public health services. 80,000 just for the minimal public health services. Also, we saw from Trust for America's Health, they highlighted that the public health workforce has shrunk by nearly 56,000 positions, primarily due to funding crisis. So this issue around support for public health infrastructure and making sure that we have the resources to support those needs, as well as the workforce, have been highlighted time and time again. So the question is, what is CDC doing to address some of this? Next slide. I want to highlight two major changes, which you've heard about, really geared towards supporting and strengthening our public health infrastructure. I'll start with the new National Center, which I mentioned, then I'll give an overview of the grant program. And these are just two approaches. This does not really impact the ongoing work that we do in our funded categorical areas to support workforce and infrastructure needs. So next slide, just for an overview of the new center. The goal of the new center, which I'm honored to say I've been asked to serve as director, will focus on strengthening public health infrastructure through effective and efficient delivery of public health infrastructure and workforce development services. The center will have three primary functions, which are highlighted here: jurisdictional support, and this includes our broad non-categorical grants and cooperative agreements that serve as mechanisms to provide funding support to jurisdictions and tribal communities. The second is partnership and technical assistance, and this includes those mechanisms that we use to fund our partners to move our collective public health goals forward. And then the third, which I'll spend some time talking about, is workforce development, which is why I thought the first segment was really nice lead into this. We really view our public health workforce as our most precious asset. We simply cannot do the work of public health without a competent and prepared workforce. So a focus on public health workforce is a key function in this center. Next slide, please. I briefly want to share that the center, though not evident in the name, will be a science-based organization focused on evidence-based solutions to push our work forward. So we do have three cross-cutting scientific functions that we will focus on. The first is data management. This report refers to the data related to reporting for our grants and cooperative agreements, as well as our workforce-related initiatives. And I should mention that the workforce-related functions in the center focus internally in collaboration with CIOs across the agency, as well as working really closely with our human resources office on enterprise-wide approaches to strengthen our internal workforce, as well as our support to state and local through our fellowships and internships and training programs, and through investments that we make at the state and local level. So managing that data is going to be a big part of one of our cross-cutting functions. The other is the systems and infrastructure. And when I refer to this, it's what do we use for reporting? Are there opportunities to improve those systems? This is where our collaborative work on the data modernization initiative will be very helpful, and our collaboration with the new proposed Office of Public Health Data Surveillance and Technology. And then finally, evaluation and assessment will be critical. Again, how are we looking at the impact of our work? Where are we adding value? What are the returns on investment? Are we serving communities well, who are our primary customers? And how will we contribute to the evidence base? So this will be a really big part of the cross-cutting function for our center. Okay, so if we can go to the next slide, I'll give an overview of the grant program. So it is named Strengthening U.S. Public Health Infrastructure, Workforce, and Data Systems Grant. This is now one tool. I want to highlight one because we have many grants and cooperative agreements across the agency that support workforce through categorical funding. But this is one tool that CDC will be using for addressing the challenges that I mentioned earlier. This is a first of its kind grant for advancing foundational infrastructure and workforce that is not tied to a specific disease or condition. So this is a disease agnostic, if you will. It is a 5-year grant program that recipients together with CDC, we hope can work to lay a foundation for stronger public health infrastructure. In November of last year, we took the first major step with the rollout of the NOFO to 107 jurisdictions and 3 national partners. So the important thing here is that everyone in the US lives in a jurisdiction that receives some funding from this program. So let's go to the next slide. In addition to the states, territories, and freely associated states, the grant also funds 22 cities and 27 counties. And so if you're interested in really looking at details here, we have this published at our website at cdc.gov/infrastructure. Next slide. Now to go through the components of the grant, which is what I think the committee was interested in. The grant is broken into 2 components, A and B. Component A, to directly support the 107 jurisdictions that I referred to in strengthening public health capacity and systems. And then component B, to support the 3 national partners that were funded in providing technical assistance to the component A recipients. So component B supports recipients of component A through technical assistance, thinking about evaluation, and we are working very closely with them on those, the planning for that. If we can look here, go to the next slide, I think. Look at some of the key strategies for this. So I mentioned 107 jurisdictions. At the top, you can see who was funded. I just kind of wanted to walk through a few of the strategies here. So around workforce, we are looking at how we recruit, train, and support our public health workforce. This is a critical component of the grant program. I did want to highlight once again that along with this, we are working with colleagues across the agency to see how these strategies for this grant program can complement strategies that are already underway through other grants and cooperative agreements that provide workforce funding. So just to be clear that this is not the only mechanism that's used to look at funding our workforce. The other strategies around foundational capabilities. So there is some flexibility here and utilizing funds to strengthen systems, processes, and policy. And then the third strategy is around data modernization. And this is where our close collaboration with our colleagues in the office that Jim Layton talked about, the proposed Office of Public Health Data Surveillance and Technology, will be really helpful. This is a mechanism by which we can provide funding to support our data modernization initiatives. So first, beginning the first year states, I just want to highlight a few other points about the grant. State recipients will distribute at least 40% of their workforce funding to local health departments. This is important. Second, it's critical to highlight that recipients do not put additional administrative or reporting burdens on local health departments. That was some of the guidance that we provided. Lastly, I want to highlight that recipients should identify other cross-cutting sources of CDC funding received to determine how they might best support some of those foundational capabilities. So this is intended to serve to support other sources of funding and investments in those areas. We know that these are huge investments, but it is not enough. So we are already thinking about how we will be moving towards evaluation and looking at how we can really show return on investment, how these are supporting and serving as a bridge for other investments and really making the most out of these resources. But I wanted to highlight that there are at least 2 dozen other, I think we found close to 40 grants and cooperative agreements that have some component of workforce associated with them. So working together on those other mechanisms to see how we can really show value is going to be important. Okay, let's go to the next slide so I can give an overview of component B. So component B does have a narrow focus. The 3 national partners who received funding were the Association of State and Territorial Health Officials, the National Network of Public Health Institutes, and the Public Health Accreditation Board. And these partners are working together. They will be working with additional partners through sub-awards to provide funding to support those recipients of Component A. The key activities to provide Component A recipients with technical assistance and capacity building support for assessing and improving workforce policy and implementation, grant program evaluation, and then coordination and communication. Okay, let's go to the next slide. I want to talk about sort of where we are. So where are we now and what's ahead? This timeline shows the progress thus far. As you can see, we have been working on this since January of last year when we kicked off the process. As a part of that kickoff, we had numerous listening sessions, and those conversations really have influenced our work every step of the way, from the development of the NOFO to our engagement with our partners, to support on working with programs and the development of their work plans, and then now on how we're going to evaluate the progress of this program. The final recipients turned in their work plans earlier this week, so we are really seeing progress here, and we will share work plans, performance measures, and success stories from the jurisdictions as they are available. Okay, let's go to the next slide so we can talk about some of the key outcomes that we're expecting. So we've outlined these, that jurisdictions they do have some reporting requirements and some things that we expect to be achieved by the end of the 5-year performance period. However, this is a very flexible program, and we're excited that this is flexible. One of the requirements for this grant program on the workforce component is that every recipient was required to develop a workforce director that will be responsible for looking at their entire workforce needs and helping to develop their workforce plans and working both with CDC and those funded partners under the component B of this grant program to really think about using those resources around workforce wisely. But otherwise, this is pretty broad. And while that's great, because we heard when we engaged at the state and local level that broad and flexible, non-categorical funding was important, we know that that also raises some risk. You know, there's this sort of balance, and we can go back, please, back to the last slide. There's this balance of having flexible funding, but also making sure that we have some outcomes here. So some of those that we outlined here for short term around workforce was increasing hiring of diverse public health workforce. We highlighted this in the language of the guidance that was provided here. We're also looking at opportunities to improve organizational systems and processes. This is that foundational capabilities component. And then utilizing the funding to really support and strengthen some of the ongoing data modernization work that was previously funded. In the intermediate outcomes, we highlighted increased size of public health workforce, though we realize this is only one mechanism to strengthen workforce, stronger foundational public health capabilities, and then increasing the availability and use of public health data. On component B, continuing to work with those recipients on improving and sharing lessons learned, so we use that to inform our processes moving forward. Okay, let's go to the next slide now. Thank you. I did want to talk about evaluation because I mentioned that this was really foundational. We have to be sure that these investments really show a return on investment and that we're having some public health impact. So the evaluation component is a critical part of the success of this grant program. We will be tracking progress, documenting success and challenges, trying to drive improvements where we can, and then build evidence for interventions. We want to use also some existing assessments from partner organizations to build on the work that's already been done while continuing to reduce burden on data collection from our recipients. So the performance measure reporting will complement work plan and financial reporting. Okay, let's go on to the next slide. Okay, did want to talk a little bit about performance measures. We are planning a set of limited performance measures that component B recipients will report on a regular basis. These measures, which include both process and outcome measures, will be finalized by component B evaluation partners in the spring. While we are preparing for that, we are working closely with partners and engaging with other organizations to get input on what should we be considering as evaluation measures. We are already thinking about 5 years from now. We know that there's a lot of visibility on this program and the investments that we have thus far, and there will be an expectation that we show some progress fairly soon. So while this is a 5-year grant program, we are thinking about that cliff and where we have opportunities to show our successes so that we can really, really push to get sustained funding to support the important work in our state and local health departments. So we will use the measures to monitor and assess recipients' individual and collective progress towards some intended outcomes of the grant over time. This information paired with other evaluation data and case studies will also be used to assess the grant's overall public health impact. And I think I mentioned that in the beginning of my presentation that this new national center will have a focus on evaluation. We have established a small office that will solely be focused on evaluation, looking at the data that comes in and how we really are able to assess the impact of our work, looking at measures such as return on investment, looking on measures such as customer satisfaction, engaging at the state and local level so that we can also get success stories of where these investments really had an impact at the state and local level. All of that is going to be important for us to continue to push for sustained support in this area. So why don't we go to the next slide? As a part of our, I didn't see it advance. Next slide, please. I've teed up some discussion questions. I'm sure you'll have many, but as a part of our engagement and learning about how we can utilize this mechanism to really show impact, to really reduce burden, and try to strengthen our public health infrastructure, I've teed up a few questions here that I thought would open up discussion. So I want to thank you for the opportunity to give an overview of the center and the program. Look forward to your questions, but would love to tee these up if I may. So I will stop there. Thank you.
Thank you, Dr. for that incredibly good presentation and this work that's unbelievable. I mean, it's clearly not as much as is needed, but it's certainly a great start. And so we're really thankful of the energy that you are putting into this and the thought that you're putting into this. We'll go ahead and open up the floor for questions. And let's see, Daniel Dawes.
All right, thank you so much, David. And of course, thank you, Dr. Dauphin. I was really delighted to hear about, you say health equity is really being embedded throughout the program, and you talked about increased hiring of public health staff. What I wanted to see if you wouldn't mind sharing with us, what is being done to ensure that the resources provided by this grant are targeting disproportionately impacted and underrepresented groups in the public health workforce? And also, if you wouldn't mind sharing a little bit more on what is being done to embed health equity specifically.
Thank you. Great questions, Daniel, and good to see you. I appreciate that.
You too.
As I mentioned when I gave the overview, there's some very specific language on the workforce in the guidance for the workforce component. That's component A1 around considerations for diversity, equity, and inclusion in the hiring. So that's one aspect of it. regarding thinking about those communities, this is where our work with those funded partners is going to be really helpful. You may recall that I mentioned that these partners actually have will be sub-awarding to other groups that have an opportunity to really make sure that as we are staffing up, that we're thinking about those reflecting the communities that are being served by these investments. So with regard to diversity and equity inclusion, we do have some specific language there. Now, with regard to health equity, this is really, really all about access. And so when thinking about the component A2, where we think about those foundational capabilities, this is where there's a real opportunity to think about strengthening some of the policies, systems that are really critical to thinking about access to health in our communities. So we think that through the guidance and language around thinking about the workforce component in hiring, and as well as the foundational capabilities, we're considering both diversity, equity, and inclusion, as well as health equity as a part of the program.
Thank you.
Thanks. We have a number of questions. Octavio.
Thanks, David. Thanks, Dr. Dolphin. Great presentation. One thing that it made me think of, and especially in reference to the number of grantees that you definitely have you considered, or are you thinking about creating a learning community among your grantees? It's a great, model for not only accountability to each other, but obviously also sharing of challenges and successes. We've had great success with that in working and trying to change rural communities here in Texas. I see you're shaking your head, so could you share some of that, maybe conceptualization of how you'll have a learning community part of the process?
Yes, thank you. I'm glad you raised that. That is actually something we've been thinking about through two parts of this. So the first is, interestingly, I'm learning that through some of the work plans that have been submitted, some of the recipients are already thinking about doing this. So they are already thinking about doing this, which is fantastic. And then through the component B, where we're working through our funded partners, this is one of the ways in which they're thinking about sharing and providing the technical assistance. Where can we look at those who have been very successful and learn some of those best practices and share with others? So through both the work plans that are being established by the recipients and our work through our funded partners, I am certain that this notion of sharing through community practices or networks is really going to be a component of this program. And we have to rely upon that, right? I mean, this is really how we're going to make some progress in the very short time that we have to see results from this program. So that's a big part of it. Thanks for that.
That's great. And it also segues very nicely with Daniel's point, because you can use learning communities to also keep themselves accountable when it comes to health equity and addressing diversity as well. So wonderful to hear.
Thanks, Octavio. Julie.
Yes, I want to, this isn't my question, but I just want to acknowledge I've been a beneficiary of these learning communities as a CDC grantee, and really felt like it was incredibly valuable to hear about best practices or errors that were made or lessons that were learned to actually improve the work that we were doing with grantees. So I think that's a wonderful idea, and I'm glad that you're moving in that direction. Dr. Dolphin, thank you so much for this. Good luck with this huge center. It's so needed and so appropriate. And congratulations to you for having this opportunity to lead that group. It's just such important work. I have a couple questions for you. And one of them is kind of a response to your first question, was how do you minimize the burden on the states and locals that are grantees that are receiving this funding? RWJF has been a strong supporter of public health accreditation for years. And I am in my role at Chicago, we actually went through the process both for accreditation and reaccreditation. And so I see the value and understand the purpose of it. What I would say is that it was an incredibly burdensome process. to get through to become accredited. And so I'm wondering if you all are working with FAB to actually see if there's ways to streamline the process, because I think in the midst of trying to rebuild an infrastructure, rebuild a workforce, the thought of having to go through a really burdensome accreditation process is really, I think, would just be demoralizing, or I could see it being demoralizing to the cities and states that are trying to get through this process. So while I see the value and appreciate the value, I would just hope that there's efforts being made to streamline the process. And then my second question was, in your description of the funding and what's been made available, the data modernization was identified as an area, but it says it's not funded yet. And I wonder if you could elaborate a little bit on that, because I think there is funding that's coming. I was curious if you could elaborate on that. So thank you again for all your work and the work that lies ahead of you. You've got a huge challenge.
Thank you. A great question. So to your first question, yes, absolutely. We are working with FAB. This is a lot of ongoing discussions about exactly what you raised, that sort of burden and the challenges. So I should clarify that in the language and guidance for the grant program, there's not a requirement to achieve accreditation. There is language that encourages moving towards accreditation, and that could be one area where we could look at measures for success of this program, but it's not a requirement. It's really, there's a lot of flexibility here, Julie, in how recipients choose to use the funding that is to support the foundational capabilities. The point that you raised continues to come up as a discussion topic. And I should mention that a part of the functions and scope within the new National Center is really around technical assistance for public health accreditation and how we work with FAB and other partners in thinking about that. So these are definitely discussions that are underway, and we have heard that loud and clear through some of our engagement, that while we want to incentivize moving towards some measures that can really show impact, that it is extremely burdensome. And how do we work together to look at streamlining processes and where we can actually see moving the needle forward towards those foundational capabilities, even if you don't achieve accreditation. So that's for your first question. The second question, yes, regarding the component A2, data modernization, did not list funding in the slide because the funding has not rolled out yet, but we absolutely do have plans to send funding out. We had committed to utilize, so we can use base appropriation. The nice thing about this grant program is that we can use a variety of funding sources to go through this mechanism. There's a lot of flexibility there. We do have plans to initially roll out. We committed to 40 million of FY23 appropriations for data modernization initially. And we're looking at where there are opportunities to leverage work that's already gone out to support DMI through the Epidemic and Laboratory Capacity Cooperative Agreement. I think there was a question about that earlier, and support that ongoing work through the funding that goes out through the component A2 of this grant. So it wasn't listed because it hasn't rolled out yet, but we do have plans to roll out FY23 funding through this mechanism.
Thanks. Really good to know. Lynn.
Thank you so much. And thank you very much, Leslie, for that presentation. And it truly is wonderful to see the beginning of a process where what I would call core support is going to the states, and particularly that you are making sure a lot of it is reaching the local level, and even giving special support to cities, and who obviously sometimes get shortchanged. There's a lot I could say about all of that, having at one time worked for a very large state, California, and we never felt, that the amounts were commensurate to our responsibilities for, 1 out of every 8 of the people living in the country, but certainly never had 1 out of 8 of the dollars. I'm sure that's true now as well. But I do think that, there's probably further work that you guys could do. And one of the things that, this is a good beginning to, in terms of, I see the care that has gone into minimizing the bureaucracy and the burdens. And I think some of what Julie asked about kind of went to that. But there's still a lot of support that's coming from CDC to state and local government that is in silos that each, do create burdens and bureaucracy, much of which is not necessary. And some of it exists as if though there's no other CDC program that people are involved with. And it really is, I think, incumbent on all of us, and perhaps Dave, in an area, where the ACD could once again get involved in, just as we can, I think, streamline a lot of the data collection processes. There are ways that these our grants are being implemented that could be streamlined, that could make it less burdensome for the states. And I think what Leslie is doing is maybe starting to lead the way for that by creating paths, for more general levels of relationships. So anyway, I appreciate it, and I think we have a long ways to go. There's so many needs, that the infrastructure has, and every time that people are doing unnecessary bureaucratic stuff instead of their jobs, that is not necessarily, benefiting the public's health. Thank you.
Lynn, I so appreciate that you raised this. One of our priority areas in the new national centers, we are at our core, we have identified collaboration across the agency as a core value. And so we are committed to working with our colleagues across the agency to address just this thing you mentioned. If nothing more, we would really like to convene a forum where we have opportunities to look across all of our grants and cooperative agreements and say, hey, where are there opportunities to really streamline how we're doing reporting? Not just the processes, but also the systems. This is why I mentioned earlier, our work, internal work on looking at our systems and working closely with our colleagues in the Office of Public Health Data Surveillance and Reporting on enterprise approaches. This is one of the areas that we're targeting. So we are very much interested in, as a priority area, working with our colleagues across the agency on where we can reduce burden. And we welcome, actually, that was one of the questions I had teed up. We welcome any input from the ACD and others on ways that we can do this. So thank you. I really appreciate you raising that.
Monica, last comment.
Thank you, David, and thank you, Dr. Dauphin, for walking us through those updates, and congratulations to you on this new leadership role. Having been at the state and the city, I really appreciated the partnerships and support when it was O stilts and then C stilts, and just your emphasizing your commitment to working in an enterprise way across these centers and with your partners is really reassuring. Your slide on the questions, so the second question, the bullet about things that would be helpful to learn about. We know that during the pandemic that a community-based workforce really was able to emerge and to be extensions to the work that our local public health and state public health partners were doing to respond to COVID. And then the workforce kind of waxed and waned, and depending on the jurisdiction, some were able to become permanent hires. And so I think as you're pouring through the work plans and some of the themes are emerging about the different strategies and approaches, something that would be helpful to understand is where those jurisdictions have been successful in actually making sure that the communities are reflected in the workforce moving forward. So that was one comment on the questions that you shared. And then a question for you about clarification, because I've heard about this 40% subaward to locals. And so can you just please clarify, when the 40%, is it to local health departments and or community-based organizations, or is the 40% to local health departments who then might have that flexibility to then work with community partners?
It is the latter, and thank you for asking that question. The 40% to local health departments, and they will have some flexibility in how they use that. And to your first question, which I think is really fantastic, yes, I should highlight that I was asked to talk about the new center and the grant program, but there are other efforts that we have related to workforce to really think about community-based work. And I did want to mention just briefly Some of you may be familiar with our partnership with AmeriCorps for Public Health AmeriCorps. This is the first of a, and this is a program that is funded through the American Rescue Plan to really get at looking at pathways for workers in communities. And we are really, really proud of this. This gets back to Daniel's question earlier about how we're thinking about health equity. This is a holistic approach where we're thinking about all of our workforce related programs. We're looking at all of our infrastructure related activities around grants and cooperative agreements. It's not only this, it is really a multi-pronged approach at looking to make sure that how we are planning, implementing, and evaluating all of our work with health equity principles in mind. So I just wanted to highlight that partnership because it wasn't in scope for this presentation, but really does get at just the core of some of the questions you're asking about. And I would love, if you're interested, to just take a look at the work that we've done with AmeriCorps for Public Health AmeriCorps. It's really fantastic. We're now in the second cohort. We have over 3,000 grantees. So, I mean, this is really a pathway to public health workers. We know that hiring alone is not enough. We've got to have really a multi-pronged approach to thinking about our workforce through our training, through our fellowships and internships, and through pathways. So thanks for that question.
So unfortunately, we're at the end of this session. Dr. Goffin, thank you so much for your presentation, for your work, for your leadership. I feel like we're just at the beginning of this pathway with you. And so if you are willing, we would really much enjoy the opportunity at future ACD meetings of reconnecting with you and continuing to be able to ask questions and perhaps provide some input to you as well.
Absolutely. I very much appreciate that and look forward to it. Thank you so much for inviting me.
Well, thanks again. Now we have one more session before our break. And so I'm delighted now to turn this over to our Health Equity Work Group co-chairs, Daniel Dawes and Monica Valdez-Lupi, to lead us through a discussion, a vote, and some brainstorming. So over to you, folks.
Fantastic. Well, thank you so much, David. And of course, on behalf of Monica, we are delighted to co-lead the Health Equity Working Group. Just want to thank you, Monica, and of course, David and the entire team. Una, Carrie, Bridget, Deb, it's been a just really a team effort here. And of course, in conjunction with our exceptional HUE members, we are really excited to share with you some updates today. So next slide, please. Thank you. So to help Dr. Walensky and of course the CDC leadership as a whole meet their objective of actualizing health equity, we established a working group of 21 health equity members, consisting of 11 ACD members and 10 additional members, with expertise in population groups that are disproportionately and disparately impacted across the United States. Intentional about making sure we focused in geographic representation, racial and ethnic, disability, LGBTQ, ageism, and so forth. Next slide, please. And to better manage our charge, we created 3 task areas. Task area 1 was to enable and assure the meaningful involvement of communities in agency decision-making, the development of health equity policies, program implementation, of course, evaluation. That was the first task area. The second task area looked at aligning and restructuring as necessary CDC policies, resource allocation, and program practices so as to maximize the ability for staff and partners to address health inequities in their day-to-day work. And then task area 3, in concert with communities, was looking at taking immediate and decisive action to expand, embed, and integrate approaches to measure and influence drivers of health equity across all public health programs. So looking at the determinants and drivers of health as a whole. I'm going to pivot to Monica now, who's going to give us an update on our work thus far and how we're going to move forward.
Thanks, Daniel. And just also want to acknowledge that I think we have some work group members who are also watching this portion of the meeting. So thank you for all of our HUE members who are joining us remotely too. So just to recap, as Daniel said, we all met in person last November, and the advisory committee approved in concept the recommendations that we shared in draft form under task areas 1, 2, and 3. And since we met in person in November, Daniel, David, and I have worked with our CDC colleagues in terms of streamlining the report and also hitting the pause button in some of the work that we are doing, and wanted to share that with you as part of the next steps updates. What we have been talking about is the possibility of the HUE providing some additional specificity and making more of the recommendations under task areas 1 and 2 specific and concrete to help with going ahead and implementing and operationalizing the recommendations, as Daniel has said. So we'll talk a little bit about what that means in terms of the work itself. Between now and our next meeting, which will be in person in the spring. But it will create some opportunities for the HUE to work with CDC's Office of Financial Resources potentially, and the Office of Grant Services to just make sure that the recommendations are as specific as they can be and implemented in this new structure that Dr. Walensky had walked us through at the top of the call. This afternoon, we'll have David go ahead and present task area 3 because it is approved and ready for implementation, and I believe a vote to move forward by the advisory committee. And so these task area 3 recommendations, which David will walk us through, are specific enough that our understanding is that our CDC colleagues will be able to move forward implementing each of those. So David is going to share a high-level recap, and we can move towards a next step related to task area 3 specifically. And then we'll come back to Daniel and me to quickly walk us through some of the questions that we're working through with our CDC colleagues. So next slide, and I'll hand off to David, please.
Thanks so much. Yes, so there were, when we got down to this 3 task areas and 2 co-chairs. So I got the lucky job of taking on the 3rd task area, which in some ways was more straightforward. And we're bringing that forward today to you for a vote. That's been provided in your packet as well. You have seen much of this as well. There's been a little bit of streamlining of the language and the specifics, but it's basically very similar to what you approved at the last meeting. And just to recap it, in task area 3, the basic concept is to urge CDC to adopt an agency-wide approach to working on equity and health equity. And we divided it into 2 parts. The first part is to encourage that agency-wide approach to identify and implement measures of the underlying drivers of equity and health equity in ways that make them accessible and useful to the communities and to public health programs. And it consists of some subparts, including recommending that CDC lead a process to synthesize what's currently known about this issue, to initiate a process with the key partners and stakeholders to assess the feasibility of developing and implementing field tested measures in as consistent a way as possible, to assure the development of measures that include asset and solution-based approaches to equity and health equity, to focus attention on measures that are can be assessed in a timely way and locally and as granular as possible, and to promote through public health program funding the incorporation of these measures into the evaluation of public health programs. That's the measurement piece. Look at the next slide, please. Then second, we said measure is only of value if you do something about it. And so we're also encouraging a simultaneous parallel agency-wide approach to developing and integrating strategies to influence the drivers of health equity across the entire range of public health programming at CDC. Again, there's more details in the packet that you got before the meeting, but We specifically would recommend that CDC align and integrate its internal organization and leadership of health equity and social determinants. And there's some big step forwards that you've heard already in the Moving Forward initiative that we're recommending that CDC promote and enable program funding across all of its programs for assessment and mapping of the drivers and individual programs that are the most important. CDC should also incorporate funding to develop and implement strategies to change those drivers as they're mapped out, including drivers that are most important in individual categorical programs. And that these approaches that should be implemented at the program level, again, should routinely include asset-based approaches that are directed not only to individuals, but also the systems, policies, and environments in which people and communities live, work, and play. And that finally, in addition to measuring drivers, we're recommending that CDC implement a measurement of the effectiveness of these strategies and programs to influence drivers as well. So again, you've seen that before. That's in a nutshell, task area 3. I'd like to ask Daniel and Monica to introduce a motion for the adoption of these recommendations by the ACD, and then we can have some discussion before a vote. So Daniel, can I be so bold as to ask for a motion from you?
We have a motion to adopt this.
Second.
Perfect, thank you. So any discussion at this point before moving to a vote to adopt these recommendations that would then move forward after this meeting to HHS and then to CDC? If not, let me go ahead and call for, oops, Josh.
You're muted, Josh.
Sorry about that. Trying to get through one day without that. One of the challenges facing CDC in trying to do this is that a lot of these factors are not directly part of the CDC's orbit, and in fact, may not even be directly part of HHS's orbit. Is there a way to get at that at all? You know, yeah. I mean, and how do you, how does CDC become really engaged in the work of other departments, even in the federal government or the private sector, in order to accomplish some of these goals that relate to the fundamental drivers of health?
Yeah, a great point. And I, as you know, would also say that that's an issue at the state and local level, as well as public health programs are working on these issues. In the fine print of the recommendation, we try to address that a bit by pointing out that many of the interventions that are required fall in other domains, both within health and human service agencies, but more broadly in transportation or planning, or et cetera, and ask that, we'll recommend that CDC take a leadership role at the federal level in convening those appropriate groups and establishing the appropriate liaisons between CDC and the other parts of HHS and the federal system that are actually needed. And then in the program funding that's going down to states and local health departments, that be a legitimate use of that local and state funding as well to create those partnerships to assure that, as best as possible, to assure that the public health perspective of is included in the work of those other agencies that are, as you say, are fundamentally working on these underlying determinants. So we've tried to address that, but by no means believe that it's simple and will require additional work. And Ron, did I see your hand up or no?
I did, but you said what I was going to say more eloquently. My point would have been that everybody has a responsibility of integrating and coordinating, even outside of their so-called silo. And I think that's where we have a major misstep. And until we actually all own that responsibility, it just doesn't get done. So you laid it out beautifully, David. I'm going to be quiet now and drink some coffee.
Thank you, Lynn.
I just wanted to say, I think that, Josh's point is a fair one. but I think that the only way to get started towards seeing more collaboration across all the various entities, and some of them are not state and local, some of them are federal that have these data. It's not necessarily data where there's a state agency that matches each one, but I think it's a great starting point for us to support this and for CDC to be taking this on, but it is not something that can be accomplished by the CDC alone. I think that Josh's point is well taken, that they do have processes for collaborating more broadly, as do the state health departments and local agencies. And that is going to have to follow any effort on their part to make this happen. I'm thinking of, Josh, of what happened years ago when environmental public health surveillance started, and most of those data were, and were in the environmental agencies, and some of them were only federal. And over time, gradually, CDC has had more and more of that, but it still isn't what it ought to be. And so I think it needs to be viewed as a process that needs to be kicked off, and not something where, we vote for this and then it's just going to happen.
Over to you, Josh.
Sure. Yeah, I appreciate all these comments. I think the point isn't that because CDC isn't in charge of all social policy, that this isn't the right direction. I think it totally is the right direction. It's just that a critical part of what CDC can do is to use those kinds of analyses that Lynn's talking about, and to kind of become relevant to some of these other conversations, and pick up on whatever strand there is of interest and engagement in other areas for this, and just really be, excited to work with people, because that's going to be, really important to go beyond the measurement into the action, particularly.
Right. Good point. And hopefully these other areas can be embedded in the thinking that goes into the measurement and actions that we're recommending here. Julie.
Yeah, I really appreciate these recommendations or these action steps. I think that they are necessary, and that building on what Josh and what Lynn said, I think that while we recognize that CDC alone can't address these issues, it needs to be able to work with other federal agencies to do this work. I don't know that CDC has been asked to play this kind of a role explicitly by anybody. And I think this recommendation, these action steps make that clear that CDC has that role and could play that important role. And when I think about it, at a local level, we did this in Chicago. We engaged with these other city partners. And it was really, like Josh said, identifying that strand or whatever it is that would be of interest to these other city agencies to work with us and see the value of our partnership and really be able to move it forward. So I think that this is what you're outlining here really helps to make clear that we think that CDC could potentially play a major role in this way, and that not that it will be easy or that everybody will embrace it, but that we have this expectation and desire for this to actually happen. So I think that's really important and good to see it in writing like this. So thank you for your work.
Thanks, Julie. I'm about to call for a vote on this. Deb, would you like to make a comment on what we've just been talking about?
Yeah, very, very much so. I think this is great. And we've done a lot of this work in our social determinants of health. I agree, like not everybody thinks CDC or public health is the convener, but in my mind, there's a great opportunity for public health and CDC to be a convener across these different disciplines. So I think this is newer, but it makes sense to me. And I think it's something we are supportive of and delighted to really be able to look at how we can focus more on social determinants, drivers of health equity, and thinking broader. So really appreciate the committee's thoughtful time on this action step.
Thanks. Although we're about to make them recommendations.
Yes.
So we have a motion to for the ACD to make as official recommendations to the CDC the action steps that have been outlined in task area 3. All those in favor, please signify by saying aye or raising your hand or some other way affirming.
Aye.
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 Opposed? Are there any abstentions? Fantastic. Motion is adopted unanimously by the ACD as recommendations to CDC. Thank you very much, folks. A big step forward, and we're now going to hear about some additional big steps forward from Daniel and Monica.
Well, thank you so much, David. Next slide, please. So as you heard from David and Monica, we're working diligently to provide additional specificity for recommended actions for task areas 1 and 2. And what you see on your screens are areas that we'll be meeting with CDC to dig a little bit deeper and provide more specificity on it. And so what we tried to do was to bucket them in these general areas and develop some questions that we believe is going to help us to accomplish this objective. So I guess for task area 1, we're really focusing right now on the current rules, policies, and practices related to community engagement and community participation. And I think this is especially, a sensitive topic for those of us. I obviously just moved to Tennessee, and we have an issue now with the Tennessee Department of Health deciding not to take CDC money for HIV/AIDS work. It's quite interesting to see how do we work then to ensure that the people who are really closest to the pain and the problems of many of these public health issues continue to get the resources that they need. And so some of the questions that we will be asking, and we welcome your thoughts on additional questions, include, if you look at the first bullet, options for community engagement and input. One question is understanding that to advance and ultimately achieve health equity, changes to CDC structures, their processes, culture, and policies are required. What needs to be changed in order to effect positive changes to allow for the advancement of health equity and the prioritization of community engagement, as well as increased funding and resources to non-governmental entities that are working to bolster health equity? When we think about ways for communities to participate in decision-making, some questions that we've come up with that we'll be asking CDC is, can CDC organize community-based listening sessions prior to releasing NOFOs to help inform developing NOFO language? Or does the CDC have the ability to build in approaches to STILT programs that help integrate communities in decision-making and resource allocation through NOFO requirements? And as another example, how much flexibility does CDC have in the application or NOFO process, and as part of an extended timeline to require community participation? So we really want to get at concrete examples, specificity in how communities can participate in the decision-making process there. And then the third bullet, understanding and influencing authorizing appropriations language limitations. Some questions that we developed was, does congressional language explicitly preclude or explicitly limit funding to certain entities, specifically non-governmental entities? How does CDC's congressional liaison and other staff work with congressional staff in developing appropriations and authorizing language for bills? I think it will be interesting with the new position, the Director of External Affairs that Dr. Walensky mentioned. It'd be interesting to see how that person will be working in influencing and ensuring that appropriations and authorizing language include this. I'm going to open it up for questions, comments, additional ideas that we may use to probe as we move forward with getting more specificity for task area 1. Any reactions, any thoughts? Yes, Deb.
I can start the conversation. I think it's really helpful to give us guidance really on this. I know, Monica had given an example that was at the state level. And so I think understanding if there's a lever that's at the state level versus the federal level, to really unpack where some of these barriers are, that's really helpful, because if it's an artificial barrier, we can address it. If it's a state level, we can work with states. If it's federal or congressional appropriation, that's harder for us to work with, but understanding it and being able to drill down, it's really helpful. So I think the more that you all can help guide the questions, that would be great for CDC to be able to pull that data and information for you.
Thank you for that. Josh, I see your hand next.
First of all, I think this is a great topic. really great topic to focus on, because the processes are often, kind of boilerplate used, but they're a really untapped opportunity. I wonder whether, when you might think about asynchronous ways for people to contribute, like if they're not able to attend an advisory board or listening session, and ways that people can, weigh in writing or videos or other things when they have time if they hear about it. The other thing, I don't know whether this is within scope, but there may be certain policies, et cetera, that it would make sense for the CDC to propose and draft for comment. Typically what happens is, this is not just the CDC, people go out, they get input, and then here it is, here's what we're doing. And then they might explain a little bit about, how they took it in, but they haven't really thought about a bunch of things, and then people get upset afterwards because, now that they actually see what the agency had in mind, it brings up a whole bunch of other thoughts. And one way to do this that can actually keep things moving forward is for the agency at some point to propose, even if it's not like a notice and comment rulemaking where proposal is actually required, but you propose what you're thinking just for comment. This is how we're going to be doing the grant, but it's a proposal. Does this make sense? And then people can say, wait a second, this wouldn't allow our group to apply for this reason. And you're not dealing with it afterwards, but you're able to get the information up front. So in general, I don't know whether that's considered in scope, but I consider proposals a kind of backdoor way to do community engagement. The other thing is, like, media and everybody revs up when you see the agency's thinking. So like the word if you just say like, oh, we're having a listening session on this grant, okay, fine. It's like the grant's proposed and it's going to work in this way. That really helps kind of energize the proposal. And for CDC, it could really make clear everyone's position, so they're making a final decision without, with the full knowledge of the landscape. Anyway, thank you.
Thank you, Josh. That's it.
If it's okay, maybe we could move on to the second one, and then people who have comments on either the first or second can chime in.
Sure. So next slide, please. And I appreciate your suggestion, Josh. We used to do that all the time at the city and the state in the form of a request for information and in terms of gathering feedback. And I think that is the spirit of these two task areas, is really to open up opportunities for resources to go to a more expansive group of grantees. Even listening to Dr. Duffin talk about the 40%, the funding, the majority of the funding, my understanding, is that it does flow to the states and local health departments and directly to some big cities. And so for task area 2, that is really the spirit in which I want to present some of these follow-up questions, is really looking at exploring specific business practices and different rules that can help guide resources and the ways in which funding can be distributed to community-based organizations. Let me pause and see, Lynn, is it okay if we come back, or did you want to ask your question now?
It's fine to come back. I actually, all I wanted to suggest, having been on the board for very small not-for-profits who have received grants from CDC, is bringing in some people with lived experience of what these processes really look like and the burdens that they create, which are considerable in proportion to the budget that these small organizations actually have. That's all I wanted to say.
And that's a great suggestion. And that actually came up when we met in person last summer with our Colorado colleagues, and a specific issue around advance payments, especially for nonprofits, because many times grants are set up with states and cities on a cost reimbursement structure. Is that required? Is it necessary? Not sure. So I think your suggestion about lived experience and actual real people who are receiving grants and leading nonprofits is important to inform recommendations that we'll be making. But again, like Daniel described, these are sort of the overarching categories of questions. And so just a flavor of some of the things that we'll be asking our CDC colleagues to provide more clarity on is around the current status of funding that's provided directly to CBOs. are they tracking that? How much of their funding is actually going to CBOs across the agency? Which programs are mandated because of authorizing language to go through governmental public health at different levels? On the second bullet, understanding the ways in which funding is structured at, stepping outside of authorizing language, but within the centers, how does CDC and the different programs and divisions determine whether funding will be distributed competitively or formula, and getting a better handle on that, and whether there's any flexibility and in influencing competitive criteria? So could the CDC require certain demonstrated partnerships, for example, with community-based organizations? Could that be a criteria beyond just some of the NOFOs and grant opportunities? Provide a list of community partners, but beyond providing a list, how can CDC gauge true, authentic, meaningful partnerships with community-based organizations? And when we began this process, learning about CORE, there were colleagues within CDC from Dr. Hacker and others who were able to share exemplars that currently exist. We heard some of those examples last summer with the 2103 health equity grants that were provided during the pandemic. And there are also sister agencies like HRSA that have a really robust community advisory board mechanism in terms of those different pots of funding coming from HRSA Ryan White. So being able to look at those and scale those across the agency. The other categories around just identifying where there are barriers that limit their ability. Are there barriers? What are the actual rules? Is it in statute? Is it an administrative policy or procedure? These are things that would be helpful, I think, for the HUE to explore with our CDC colleagues so that we can understand where there are really truly barriers and where there are opportunities to get those funds out to community-based organizations. And then finally, understanding what mechanisms might exist for TA and capacity building to support CBOs. We want to understand if there is any flexibility or ability to restrict or limit payment for different financial models, something that we just started to talk about, where advanced payment and the payment structures that go out in different grants, cooperative agreements, contracts, and understanding those policies and procedures. Understanding how CDC may be working or partnering directly with CBOs beyond what the state or local health departments might be doing to promote funding opportunities. That 40% example to locals in the public health workforce infrastructure grant, I'm not sure if community-based organizations understand yet or are aware of opportunities that they might have to partner with their local health departments in building that future workforce at the health department. So I'll stop there, and it looks like we have some questions teed up, and it looks like Dr. Meadows. Rhonda, your hand is up.
Yes, so I agree with everything that's laid out. I think it's well done. I have a question though. How do we get in the part where we get feedback from the people receiving services? You kind of get what I mean? So we're talking about the people who receive the grant, provide the service or the solution. We've got the local public health department that's kind of being the grantor, right? Organizing it. But how do we get the actual input back from the people in the community, from the public? Because I think if we don't intentionally either build it in a requirement, I'm concerned, right? So some of the community groups ordinarily would get feedback from the people who are receiving their services. And some of our health departments do a fairly decent job about actually, but I think it needs to be, particularly for the health equity work, that we are calling out the need to get specifically information from the community. And it's not about whether or not a grant should be given, but the effectiveness of whatever it is that's being provided. That make sense to you?
Yes, very good point, and I'm much more familiar with how we got community feedback at the state and the local public health department levels, but certainly you're right in terms of the effectiveness of how how the resources are flowing to actual communities. I picked up on something Dr. Duffin said. She actually said that the communities are the customers, right? And so I think you raise a very important point about how CDC can gauge the effectiveness of those dollars as they're being implemented. So we'll make a point of that. Julie?
Yeah, I think it's great. I love the way that you're diving down deeper in terms of trying to understand, get more specific about what each of these task areas is focusing in on. And I actually saw there's an opportunity for overlap between task area 1 and task area 2 when you looked at you identified looking at the exemplars, because I feel like Ryan White is a great example of an exemplar both for funding, but also in terms of community engagement because of the expectations for engaging with people with lived experience as part of decision-making for allocation of resources. So there is this, so I think as you're looking at exemplars, I feel like that example might also serve a good example for how you do community engagement in a way that actually informs decision-making in addition to allocation of resources, because I think it's both. It's a great example, and I think there's a lot that could be learned from that kind of an approach. And it gets at what Rhonda was mentioning earlier as well in terms of hearing from the community in terms of how these grants are actually affecting them and reaching them.
Thanks, Julie. And I would welcome other examples from ACD members. If you're aware of them, you can share them offline with me, Daniel, and David. Ryan White was the one that came immediately to mind, but there may be others. Healthy Start is one example. I know when I was at the city where we did have community coalition, but that's different than the Community Advisory Board, which was written into the law, right, into the Ryan White, the statute. So any other examples, we would welcome those so that we can put those into the discussion.
So maybe I'll just add this because nobody else has their hand up, but the community health needs assessments that public health agencies are doing throughout the country many of them are using these kind of community engaged approaches to hear from community directly in terms of as the public health agencies are building health improvement plans, what needs to be prioritized, what's working well, what's not working well. And so those are models I think that are existing, and some places do it better than others, but it seems like that might be an opportunity to explore those as potential exemplars.
Thanks, Julie.
Hey, thanks, Monica and Daniel. I think we'll go ahead. We've got some great input. It sounds like, first off, we have a fair number of the ACD on the health equity work group, so we can continue to tap them, and we'll continue to work with folks offline as well for this important work. But I'm sensing a lot of excitement and enthusiasm about the approach that you've laid out. So thank you very much. And we're now going to take a break. We went a little bit over on this, so what I'd like to do is to give us a 30-minute break rather than 35. We'll start up at about 5 after the top of the hour. This is labeled lunch break, which is applicable for those of you on the East Coast. Where I am, it's more like a breakfast break, and we have a brunch break for those of us in the middle of the country. But let's go ahead and take that 30 minutes and come back at about 5 after the hour for our laboratory working group report. Thank you very much. So by my clock, it's 5 past the hour. Let's go ahead and remove the slide so we can see the ACD members. And I'd like to ask the ACD members that are back from lunch, if you could turn your camera on, and so that I can see who's here. We're getting a note from Josh saying he cannot turn his camera on. Is there something that it's good to know he's here, but it's important to have his camera working for this presentation. And can we go ahead and temporarily remove the slide so it's a full view of the ACD members? Maybe not. There we go. Thank you. And there Josh is there now. So I think we're getting pretty close. I see Daniel, Julie, Lynn, Crystal, Jill, Octavio, Josh, and Ada. I think that gives us quorum. 1, 2, 3. Yeah. Good, thank you. So we'll go ahead and get started. And we're going to now move into the laboratory work group report, and that will comprise our afternoon, an entirety of the afternoon session. Let me turn this first over to Deb for a few remarks.
Great, thanks, Dave. And I hope everybody had a good breakfast or lunch break. I did just want to mention in fiscal year 2022, Congress directed the Secretary of Health and Human Services to establish a task force that included participation from outside stakeholders and subject matter experts to evaluate what contributed to the shortcomings of the first COVID-19 tests and what policies, practices, and systems should be established to address these issues in the future. Through an agreement with HHS and Congress, the advisory committee to the director, through the laboratory work group, has served as a task force requested by Congress. CDC welcomed the in-depth review of the work group conducted of its laboratory policies, practices, and systems under the direction of co-chairs Drs. Jill Taylor and Josh Sharfstein, and we look forward to hearing the presentation of their work over the past 6 months. And I truly want to thank them, as well as the CDC staff that provided a lot of time and input, and the lab work group for what I believe will be a comprehensive review, action steps, and discussion. Thanks.
Thanks, Deb. Yes, this has been a great working group, and my thanks in advance both to Josh and Jill, but also the entire working group. And without further ado, Josh and Jill, you have the floor.
Great, thank you so much, David. And Jill, how are you doing today?
Thank you, Josh. Take it away. I'm well.
Great. So we've decided we're going to split up the presentation in the following way. The first part, I'm going to do the play-by-play, and Jill's going to do the color commentary, and then we're going to reverse when we get to the recommendations. So I'll go through kind of the facts, and Jill will elaborate, and then a little bit vice versa. We have several points in time to pause for questions and discussion, and at the end, we're hoping that the advisory committee will accept the report. So next slide.
Josh, just want to add that several members of the work group are listening in.
That's great. And it may be possible, if there are questions that relate to their expertise, that we could have their input. I want to say 2 things just to start, and then we'll get into the outline. The first is that CDC has been remarkably open through this process. You just heard the charge from Dr. Oury, and we have had just a really productive sessions with CDC throughout this process. It's really very much appreciated, and really, I think, reflects the spirit of like figuring out what the issues are so they can be addressed, that the agency leadership has. The second thing, and you heard a little bit of this from Dr. Walensky this morning, is that CDC has already taken some steps, and we had a number of conversations with CDC as the work group was doing its work, and I think the CDC is unquestionably moving in the direction of the recommendations that you'll hear today, and we'll be more specific as we get into it. We're going to talk a little bit about the background, and then the findings, and then the proposed action steps. Next slide. So in general, this is the purpose of the lab work group, to provide advice and work products for the advisory committee of the CDC, advisory committee to the director, regarding the effective implementation of CDC agency-wide laboratory quality improvements. Next slide. This is the all-star dream team of work group members that we had, and we have a fantastic group that really gelled when we came down to CDC for a 2-day meeting. We have state laboratory leaders, private sector lab leaders, academic lab leaders, public health experts of different kinds, and it was really extremely productive to work with them, puzzle through some of the issues we'll be talking about. Jill, anything you want to add about the group?
No, just say thank you. They were marvelous.
Okay, next slide. So this is what Dr. Oury had mentioned, that Congress requested a task force to evaluate factors contributing to the shortcomings of the CDC's first COVID-19 test, as well as policies, practices, and systems that should be established to mitigate future issues. That's what we'll be talking about today. Next slide. So in order to get at this, the work group met with experts within the CDC and in some cases outside the CDC. We requested and received many documents that we reviewed from the agency, and we developed a report with findings and action steps that's in draft form that I believe you have. Next slide. So we're going to start by telling a little bit of the background still of what we know going into this. So this isn't what we found, but what we knew going into this. And there were known failures in the first round of the CDC's SARS-CoV-2 test. In particular, there were 3 that have been well described. One is that the N1 probe was contaminated by the positive control because, and we'll get into this, because there was no actual virus that the CDC had when it was making the test. It had to manufacture the positive control to demonstrate that the test worked, and that actually contaminated one of the probe, resulting in false positive results. The N3 probe, which was binding to a different part of the virus, was poorly designed, leading to false positive results, and we'll show you that in a second. And finally, the quality control step did not detect these failures before the test kit was sent to public health laboratories. Next slide. So this is a table from one of the CDC's published papers showing the fact that the N1 probe was contaminated. And it was known to be contaminated by what the CDC itself manufactured as the positive control, because that positive control had a certain genetic signature. Anything you want to add on that, Jill?
Yes, thank you, Josh. This table in the PLOS One paper just shows, if you look at the column where the arrow is, there were 3, the CDC looked at 3 lots, if you like, of the EUA. The actual EUA kit that was sent out, the pre-EUA lot, which was used internally at CDC for their own diagnostic testing, and a commercial lot that was manufactured outside of CDC. And you can see that and what they did was that they took the false positive amplification product and sequenced it and looked for template contamination. And this figure where the arrow is shows that 30% of the PCR products showed contamination by the positive control, but only in the EUA kit. It wasn't in the pre-EUA kit that was used for diagnostic testing, nor was it present in a commercial lot manufactured outside. So this was evidence that the N1 probe was contaminated in the kit to be sent out. I think that's it, Josh.
Great. And just to be clear, when we refer to the EUA kit, we're referring to those tests that were sent to states and localities to be used that couldn't be used and created all the problem. And so this demonstrates that N1 problem. Next slide. This, the N3 probe had a different challenge, we believe, and based on the science that CDC has put forward, and that was that the probe essentially could bind to itself and create or bind in a certain way, I'll just say, that actually created a false positive result. So this was about the design of the probe itself. And we'll go one more slide maybe. And this shows that with the arrows here, finding where it says percent reads involving the probe, I think what it's referring to, and Jill can explain better than me, it's referring to the fact that there was unexpected problem with the probe being positive even when it wasn't supposed to be, believing that it was related to the way that the probe binds upon itself and other elements in the test. Jill?
And just to add to that, that problem of false positives occurred in the pre-EUA kit used for diagnostic testing, in the EUA kit itself sent out, and in a commercial lot, so that it was an inherent problem in design. It was not a problem of contamination.
Next slide. And then the third issue, all this is just background to what we were getting into. This was all established before we started, was that there was a failure of the quality control procedure. So the test was deficient, as we all know, and there are quality control procedures that are supposed to catch that. But it turned out, first of all, that an incorrect quality control procedure was used to evaluate the test kits. And it was still that test, the incorrect one, still found some issues, but when the correct procedure was performed, 1 of 3 was positive, which should have been negative. And the 33% failure results were accepted, and the test kits were not recalled. So you had the problem of the test having contamination, design errors, and then when quality control was done, it wasn't done correctly. And when it was done correctly and found a problem, it didn't lead to action. This is from the CDC's own root cause analysis.
That's good. Go ahead.
Okay, you're good? Okay, next slide.
Yep.
All right, so now our lab group comes into play, our lab work group comes into play, and the question is, what was behind these failures? We looked at the science that we just went through. No, major questions. It all was very compelling. But what was behind that? And this gets to those systems and processes that led to these problems. That was really where the lab work group focused. Next slide. Next slide, if possible. And we really focused on 4 major shortcomings. And we'll talk about these, and then we'll pause for questions after we're done with these. The first is inadequate planning. The second, ineffective governance. The third, inadequate quality control, quality assurance, and regulatory oversight. And finally, poor test design processes. So pretty significant issues led to these series of problems that proximately caused the failure of the test. Next slide. So inadequate planning. And what we found in our document requests and interviews is that there was not a plan for how CDC could develop and scale a test in this circumstance of a pandemic, rapidly. So there was no such plan. There was no, in case of, emergency break glass, inside is the plan. Instead, what CDC was really relying on was something called a graduated response framework, which was a document that was supposed to support responses with that were too big for just one office to do, but too small for agency-wide activation. And for really the key weeks of test development, CDC was operating under a graduated response framework. The overall incident command had not been activated. At that time, it wasn't really clear what was happening with the COVID, and so it was a less than full agency activation, and there was no clear plan for how to develop a test in that circumstance. The framework that we were given really wasn't relevant to test development as much as it was just there are ways to organize the agency when it's in between just the normal day-to-day and the full agency activation. Did not have a clear governance structure, particularly for labs. And it didn't really have a clear explanation for how you went from a graduated response to a full agency activation. And just sort of suddenly the incident management system would take over. So it was really an inadequate plan. And if you go to the next slide, and then I'll pause for you, Jill. Here's an example of what it means to not have a plan. The same lab had to be relied upon for both the primers and probes, as well as the positive control. So it's obviously a risk when you are manufacturing the positive control in the same lab that you're doing the actual probes in, that created a risk of contamination. But the CDC felt like it had no reasonable alternative approach. Now, I should be clear, it's not known actually. In fact, the CDC's conclusion was that it wasn't actually in the lab where it was manufactured that the contamination occurred, but nonetheless, everybody saw it as suboptimal to have to manufacture these things in the same place. But there was no plan for what to do when you didn't have the virus itself and you had to actually manufacture the positive control. And so they wound up having to do it in the same lab. Jill, anything you want to add on this issue of planning?
No. Well, yes, I do. I think that it's important in any emergency plan to have some redundancy, some backup. So, you know, things can go wrong at any point. And so this was clearly a vulnerability point, manufacturing in the same lab. And so the CDC, it would have been good if the CDC had thought, okay, what are my alternatives to do it here? And we feel that there would have been alternatives, though we realize that time was of the essence here. And so that certainly was a governing factor, but just bringing in the importance of having some redundancy in every sensitive step. Thank you, Josh.
Yeah, I think that's right. We're not saying that it was a wrong decision under the circumstances to manufacture it in the same lab, but it introduced this risk, and it was the absence of a plan anticipating that we wouldn't just be able to wait for the virus to come to make a test. We had to do it in advance. Without that plan, there was not an alternative that the CDC really had readily available. Next slide. So the second major issue is ineffective governance. So there were 3 different labs at CDC that were involved in manufacturing the tests, but they were not led by someone whose job it was to oversee that whole process. That just did not happen. That the labs were just engaging based on their job descriptions. There was no point of coordination responsibility across these labs. So if you were to say who's responsible, who's empowered to make this test the right way across all these different labs that are participating, there wasn't someone in that role. There was no clear governance like that. And that's true prior to the emergency. It was also true during the graduated response. And it was even true during the incident management mobilization, because one of the labs was not included as part of the incident management structure. So it was really a big gap in governance, that everybody was sort of doing their job, handing it off to the next lab, or just doing what the other lab asked for without somebody thinking like, is this a good idea? And that created the potential for additional problems. Next slide. Here's an example of this. There are a few examples of the consequences of ineffective governance. But one example is that it caused delays in understanding the scale and cause of test issues. There wasn't anyone who was, empowered and responsible for seeing these issues across the different labs. In addition to the fact that one lab made the positive control and the probes in the same place, there was another lab which was storing the positive control near where some of the tests were, and it's thought that that could have been where the contamination occurred. In addition, once problems started happening, the incident management leadership, which in a crisis is really responsible for the development of the test and for everything to happen, was not even made aware of the performance issues. The flow of information was not effective. So even when you had somebody who was nominally in charge of the test, they were very frustrated that they couldn't get information about what was happening, and were learning about it kind of after the fact. They did not know, for example, that the test had failed the quality control step. So it's a big challenge if you don't have a clear person responsible, and even when they got to that point for at least 2 of the 3 labs, that person was not able to get the information that they needed. And our sense was that earlier understanding of the problems could have led to different decisions on development, validation, and distribution. If they had realized that there was these problems in quality control, that might have changed the way they reacted instead of continuing to do different kinds of investigations, trying to figure out what went wrong. It would have influenced how those investigations happened and the steps that the CDC might have taken. Jill, anything you want to add to
Just
that?
the importance of having both single point of authority and very good communication. That just emphasizing the need. Thanks, Josh.
Next slide. So the third major area of the causes were inadequate quality control, quality assurance, and regulatory oversight. One of the challenges that CDC has is that research and clinical lab space is intermingled, and that creates different risks because there's not a clear quality management system for the clinical space. CLIA is a law that we'll talk about on the next slide, I believe, but it's a law that's supposed to assure quality in labs, but it is really for tests that are done at the lab. So it does not apply for the tests made for the state and locals, and CDC did not rely on its CLIA office for oversight. So you didn't have a clear quality system coming from CLIA. And then you might wonder, well, what about the FDA, which was reviewing the specs on the test? The failed quality control came actually after the CDC application to FDA. FDA is looking more at some of the design issues and not so much the quality control. And so that also was not able to catch the problem. The biggest overall issue is that there was not a clear quality assurance system to oversee the test development. And one thing that I learned in this process, not being a lab specialist myself, as we talk to people in the work group who do this for a living, is that having a clear quality system for a lab is like the air they breathe, and really understanding what the each step, what a test has to do at each step to proceed to the next step through the quality system is really important, and that was missing for this test, that level of clarity. Jill, what do you want to add on that?
Just want to add to the first bullet that research and clinical space were intermingled. We're also told that a scientist in the lab might be doing clinical testing in the morning and then research in the afternoon. And that's to us a vulnerability, especially in emergency situations where time is of the essence. You're moving very quickly. You really need to know what system you're working under. And we worry about that, and we'll deal with that. We'll bring that up again later. That was
and when
all
you
I
say
had,
what system we're working under, you mean what quality system?
Yes, thank you.
Right. And so there's a different quality system for research and a very specified quality system for clinical, and it can be challenging if it's not really clear. Next slide.
Go ahead, Josh. Go ahead.
No, go ahead, Joe. Why don't you do this one?
Okay, so for those of us who are not lab people, just wanted to remind you what clear oversight is. This is a set of, it's essentially a protocol, a set of standards that set standards for training and competency of the staff, the space, the instrumentation, and the protocols that are used. And it really applies to quality standards for lab testing that's performed on specimens from humans. So it's a rigid and rigorous system, but this is the air we breathe that Josh mentioned earlier that really does not apply to research labs. And so it's important to know that this is the oversight that all clinical, hospital, commercial, and public health labs in the country work under for clinical testing. Thanks, Josh.
Sure. And again, it didn't quite apply to the test that was distributed to states and localities.
But it would have applied to the validation of the test.
Yeah. Next slide. So during that period of graduated response, we were not able to really hear that there was a clear quality system in place. In fact, what we heard was that there was a lack of clarity around critical aspects of test design, validation, and manufacturing. The CLIA rules were not, used. As I said before, they didn't technically apply to some of this, but they weren't used. And what was put into place was described as a hybrid system drawing from different kinds of quality systems and was not considered to be effective. This relates, of course, to governance, which had there been more clear governance, it might have been possible to say, here's the quality system that is going to be used across the design of the test. Next slide. And the fourth of four topics is, and then I think we'll break for questions, is poor test design processes. So typically when a new test is developed, there are sort of a series of gates that the test goes through. There are people who will review the test, make sure that it's right. It's not all on one person to make all the decisions and then put the test out. And during that process, there may be certain steps that you go through, including using computer models to predict design failure. And in fact, when CDC went back and used a computer model on that N3 probe, it predicted design failure. It's unclear whether that was ever done in the control process. The other thing that a test design process would do is specify the criteria for releasing the test at the end. And so when the test was released, even after a failure, it indicated that something was off in the design process. So that was another fundamental cause of the more proximate failures. Next slide. Like we mentioned, that test design really reflects this last issue. It reflects several of them. It reflects the N3 issue for sure, because it might have been picked up in a better test design process, but it also reflects the quality control step, particularly without pre-specified clear criteria for what passing means. The test was distributed despite 1 in 3 kits not working. Jill, anything you want to add on this one?
No.
Okay, next slide. Okay, breaking for questions, Dr. Goldman.
Hi, thank you so much. I mean, this committee has done a fabulous job here. And I have to say that, reading your report was like reading a mystery story. You guys did a brilliant investigation, and I love the way you unfolded the things that went wrong. The one thing that I wanted to kind of explore with you guys, and maybe it's just reading between the lines and I'm reading too much into it, but it's sounding to me as if some of the organizations involved, once this moved from kind of a soft emergency to a real emergency, and CDC actually had an EOC, it appears that the labs didn't necessarily feel that they were working under the EOC. It appears that they felt they were still working under their normal chain of command. And I don't care if that's true. I don't care how you rearrange the deck chairs. And in an organization like CDC, every single person needs to be trained, in incident command structure and function, and needs to understand that in the case of a major emergency, that they report through that chain of command. They are reassigned, period. And it seems to me that even though they had an incident command structure, that training and maybe the protocols for that happening was lacking. Because after all, you can't possibly foresee every test kit you might need for any emergency, right? A lot of things are going to be developed in this fashion during a crisis. But if you don't have coordination from incident command, I mean, I think that's part of what happened. And I'm just wondering if you'd be willing to consider that, because I do think it's doable. And I'm kind of shocked when I read what you wrote here about the behaviors. I'm kind of shocked by it.
Well, thanks. I teach a course on crisis response that goes a lot into incident management and what can be done. And it is extremely important that when you switch to incident management, that everything aligns with it. And like we said in the governance section, that did not happen here. First of all, they didn't put all the labs under the incident management as we understand. And then even to the extent that they did have labs underneath, they were not reporting up. Now, I don't know that it was, we don't know why that was the case, why the people who were empowered didn't get the information. We did hear that, you know, people may have been like calling other people inside the structure, you know, but not necessarily informing the people who were supposed to be responsible for the lab tests. And so that is very much related to the governance.
So Josh, I know you teach this, and I know you know this. None of this happens unless it's rehearsed and drilled, and you know, it just doesn't happen. People continue to do what they do every day. You have to do drills, and this is not a huge recommendation, but I think they should do it. And
I think it would be fine to add something. This relates to the planning issue. You know, you really have to be able to you know, you're planning for the kind of a structure that you're going to have, and it needs to be specific about, you know, what's happening, and then you have to be familiar with it and you know, be comfortable actually doing it, and drills certainly help with that. I think it's this issue you're raising is at the juncture of planning and governance, you know, and I think that it is definitely important, and I think it would be fine to find a spot in the recommendations, maybe in some of the underlying text around planning, that we would say it's important to have governance in the plan and to practice, train and practice.
I'll beat the dead horse, but I haven't seen their plan. But they usually is, you need to create a press office, you need to create that office. They need to create a lab office that reports to the incident commander, right? They just do.
And I should just say one thing before we get to like maybe how we'll change recommendations. We haven't talked about the recommendations. That's coming next. So we can just see where the you know, if there's a little tweak that would just elevate that. I think it's in there, but elevate that a little more. Sorry, Jill.
No, that's okay. I just want to make the note, Lynn, that the individual who designed and developed this test is a researcher. In most institutions, it would be the clinical people who are in the IMS structure, not necessarily the researcher. So I think it's again looking at that IMS structure to make sure that everybody that's involved is in the structure and knows the reporting chain. But you'll see what we've suggested in the recommendations.
We can talk more about that when we look at the recommendations.
Okay, Julie.
I agree that that's an important point or concept as how this relates to incident command and also this Office of Readiness and Response. So it sounds like we'll get into that a little bit more. I really just wanted to thank you both, because I think you did a fantastic job with this report and your presentation in terms of making something very complicated very accessible and understandable, because I felt like I could read the paper. I could also listening to you talk, I could understand what the key issues were of concern. And I'm anxiously waiting to hear what the recommendations are, but I think you did a really nice job in summarizing something that was very complicated. So thank you for your efforts.
Thanks. We will pass that on to the whole group. It was really a big group activity there. All right, are we ready to proceed?
I'm sorry, Josh and Jill, can I interrupt for just a moment?
Sure.
I just wanted to recognize that Nirav Shah has joined us. And Nirav, welcome. And just for the record, I'm wondering if you would just declare any conflict of interest.
I'm a director at Steris and on the board of KINSA.
Thanks so much. Sorry for that interruption. And just relative to the last discussion, I know you're going to be speaking to this issue as well, but some of the problems that you've identified, as you mentioned, in the interim have been recognized by CDC. And so we should remember that, for example, current incident command structure and governance may not reflect what you just reported because of the identification of something you talked about.
Yeah, that was definitely something I flagged at the beginning. And as we go through, we'll mention some of the things we know CDC has done. And I should say that, just to be clear, while it may read like a mystery that we're unfolding, the CDC helped us unfold this, you know, and so we were learning from people at CDC who spent a lot of time thinking about what went wrong in order to put this assessment together. This is not sort of figured out around CDC. This is figured out with CDC.
And I just want to add to that, there is absolutely no gotcha aspect to this report. And the CDC were incredibly forthcoming and honest. And so the whole tone of the group was very much, how can we help?
All right, why don't we proceed, Jill? We're gonna switch gears. You're gonna do the play-by-play.
Okay. Okay. Can we have the next slide, please? So the second part of the congressional task was policies, practices, and systems that should be established to address the issues in going forward in the future. Next slide, please. And so we have 10 proposed action steps. And as has been mentioned before by Josh, CDC is already addressing many of these as an urgent priority. And so it's really nice for us to see our recommendations in many ways overlapping and complementing what CDC is already doing as part of its moving forward process. So let's go to the action steps. The next slide, please. So addressing the issue of who knew what in the IMS system, we believe that there should be a senior leader for laboratories reporting to the CDC director with major responsibility and, really importantly, authority for labs at the agency. We have suggested that this position should be a deputy director or equivalent position within the CDC organization. And we've said equivalent position because we are aware that there is a lot of change around the deputy director's positions, but we want to make sure that it's close to the director of the laboratory. It has responsibility and authority. And there is not a sense that let me address the clinical versus research later. Do you have anything to add, Josh?
Yes. I think that, first of all, we heard from Dr. Walensky that there will now be a senior laboratory leader reporting directly to the immediate office. So that is a major step for the agency in this regard. The second thing I would say is that there are a lot of issues that we didn't, focus on, like, the difficulties scaling the test. What was the problem with the gaps in the all the supply chain issues, big issues in testing that happened that really weren't part of the CDC's making this first test. But the work group felt like it'd be great for the person who is the lab leader at CDC to also be related to all those problems out there, that what CDC is part of a lab development system for the country, not just focused on this one discrete task of creating the first test. And it's really important for CDC to fit into that system, and there needs to be leadership coming from CDC, convening people when necessary to get to those bigger issues. So having someone at a very, very high level, it's both to assure, quality and other things that we'll get into within the agency, but also for this critically important role nationally, intersecting with the private sector, with FDA, and with CMS and with others.
Yes, so that this position should be both internally facing and externally facing. Next slide, please. So we also believe that CDC should consolidate key laboratory support into a new center. The center should focus on clinical laboratory quality, safety, workforce training, readiness and response, and manufacturing. And here I want to address the research labs, because the research labs are very important in the individual centers, but that at times for an emergency response, the research lab leaders must have a really important role to play, for instance, in lab design for a particular pathogen, in test design for a particular pathogen. So there should be connectivity. And so the center and the leader are very important in that. But in the center, it should be all about quality, safety, and all the other lab-based issues. Josh?
Just to say that again, Dr. Walensky talked about the Office of Laboratory OLSS Safety and System. And that I think, and she talked about pulling in different functions from across the agency into that office. And so this is definitely responsive to this idea that labs are a fundamental aspect of what CDC does. And it's really important for there to be an office that's empowered around these core issues to make sure that people have the right training, there's the right quality in place, the labs are safe, and just having that be a distributed responsibility has not been successful for the agency.
And really, and I'm not saying this with sort of, because I'm a lab person, the lab needs to be at the table in important decision making. And I think that it hasn't been in the past. Next slide, please. So leadership and management. The CDC should create plans for developing tests for novel public health challenges that include the governance structure to be utilized in an emergency. In many ways, as a public health national system, we need to be thinking ahead and creating tests for pathogens that have a good chance of emerging. And this is something that the external public health system should be doing with CDC and with our clinical and commercial partners. But when an emergency hits, you must have a much more defined and, if you like, rigid protocol of the governance structure so that everybody understands what it needs to be done and who needs to be told. And so the plan for the developing test should be part of that plan for an emergency. Josh?
I would just say this reflects a little bit of our discussion with Dr. Goldman earlier, and having it, something to say like to create an exercise plan, something like that would be, I think consistent with what's in the text of the recommendation. And, the interesting thing here is that it took a while to activate the full incident management, and a lot of the problems that led to those 3 areas where the test failed happened before, like the origins were very clearly before the full agency activation, which is why it's really important that CDC's planning go from the moment tests start being developed and not start at the point of the full on agency response.
Thank you. Next slide, please. So this one, we've talked before about the fact that there are clinical labs at CDC that do testing, there are labs that do surveillance, and there are labs that are basic research. And those are all incredibly necessary, but they have a different mission and they have a different oversight system. And one would not want to put the rigid regulation of clinical testing, which is incredibly necessary for clinical testing, on a research lab where you want to support innovation and creativity and allow the research leader to change the protocol when is necessary to get answers that they need. But we do feel that while there has to be cross-center collaboration with epidemiologists and basic research scientists, that there should be a strict separation of lab space and staff between clinical labs and basic research labs. This, I think, will present CDC with some logistic challenges, but I think that they are addressable. And so we as a group feel that this is a very important action step. Josh?
Just to say that right now, or pre the latest changes, I believe, that CDC has announced, there are a lot of labs at the team level within CDC. And the way I thought about this was that if you took the highest person in the hierarchy for each lab who is a lab person, you said, I want all the lab directors who don't report to somebody who knows, is a lab specialist, and you put them all in a room because we're going to announce a new policy, there would well be over 100 people in the room, which is a very difficult thing to manage if you are a lab organization. That lab is central to what the organization does. If you were to go to branch level, which I think is the direction that CDC is moving, it's in the ballpark of 30 people in the room. If you were to go to division level, you would have like a handful of people in the room. But the idea is that there should be a relatively smaller number of people who can really implement changes that are necessary, or policies that are necessary, or be responsible for all the different things that labs are supposed to do. Having it be so distributed and decentralized creates a weakness, because you can have, if you have 105 lab directors and 104 of them are doing well, you could have a big problem in the 105th. And it's just very, very helpful to have fewer people. You can hire more senior people to do that job. You can have whole systems behind them. And you don't have to, get an A in every single one, of 100. You only have to do it right fewer times. So this is the concept, I think, behind consolidating into a particular hierarchy. The other advantage that we heard from this in the discussion is that from an HR perspective, if you're in a lab that is at the team level, well, you can't, you can move around in that lab, but if you want to be promoted, you have to find another lab. And so people are jumping across the organizational chart. If there were more of a lab structure within different parts of CDC, then people could stay and just be promoted within that structure, like that particular branch or division, and that would create more continuity over time. So it's a workforce issue too.
Thank you, Josh. That was an important one to bring up about the promotion. Action step number 5, please. Next slide, please. So workforce, there's been a lot of discussion about workforce on the ACD call and today, and it's a huge issue in labs as well as in other parts of public health departments. And we believe that CDC should take very much a leadership course in creating and training a robust workforce for clinical labs. They are doing an amazing job with APHL in fellowships and internships, but we also feel that they it would be very good if CDC, in association with the regional hospitals, could develop a CPEP program for training of laboratory directors. And we think that this is a very important role that CDC should play.
I would just add that we may want to add like robust, diverse workforce, because the discussion that's behind this recommendation also talks about the need for diversifying the workforce in different ways, based and using different creative training programs in order to accomplish that goal.
Yeah. Next slide, please. So this comes down to quality, and it feels like to the team that CDC does not have a comprehensive clinical laboratory quality management system across the whole agency. There are certainly clear regulated labs within CDC, but it's not embedded in the culture. I know that Dr. Perkle has done an enormous amount of work towards this approach, but we feel that it's something that really needs to be prioritized and valued. Josh?
I think this is very much in line with the direction that Dr. Perkle has taken CDC since he has been engaged. And the idea here, in part, is that there are clinical lab quality management systems that could be implemented across the clinical labs. CDC does not necessarily have to invent one for CDC labs, but just needs to implement it. It's sort of like that part of CDC that's doing clinical lab testing should rise to the standards of clinical labs, across the board. That's really the principle. And there are a few different ways to do that. But if you're working in a lab, everyone should know that that there's a very clear quality system that you're being held to, and that will generate a quality, that a culture that when you're in the lab, this is how you proceed. It's one reason that the work group felt it was important to separate the research and clinical labs, because the research labs aren't going to follow those protocols. So if you're in the same place, not following the protocols and following the protocols, it's just harder to have that same approach to quality.
And, think about it. Is this a clear instrument or is this not a clear instrument? Oh, it's all right. It's late at night. I can just use this instrument. It just creates a system where you can cut corners. And that's just not something that we need to encourage or tolerate. Next slide, please. Break. Any questions? Dr. Shah.
Thank you so much for this great report and lots of really great recommendations. I did notice the word culture once, and it was related to quality, but are there other things that you noticed in your review? Certainly there's incredible people doing great work across the CDC, but are there other cultural aspects that might warrant a light shined on them at this point, beyond the governance changes, beyond the structural changes? Ultimately, culture has to be defined differently. Wondering if you have thoughts.
Can I jump in first, Josh? I think the staff are demoralized. And I can understand why. They've been working incredibly hard for over 2 years and having bricks thrown at them. And, public health is really interesting. Public health works when nobody knows about it. And then when something happens and something goes wrong, everybody knows about it. So it's an interesting culture to work in. But I do think that whatever CDC does, empowering the scientists is really important, because they are the best. Really, they are. Josh?
I don't think I would add anything to that. I think that the culture of quality part really came out, that it's a really fundamental expectation. And that was, when there's confusion about that, or it isn't really, people don't feel like this is what you have to do, this is the way we do things, then you can wind up with different kinds of challenges you don't want. I think that the ability to get to that culture is really partly the reason for some of the structural recommendations. Having, one of the issues that comes up is if you're a lab that you report to somebody who is not a lab scientist and just a team, and that they have a lot of competing demands on them, and don't really appreciate all the intricacies of what certain lab expectations are, it can be harder to maintain that culture. So partly the structural, reorganization that we're suggesting, and that the department, that the agency is actually pursuing, is to try to line up the organization with more support for that kind of culture.
Can I just add one other thing too? I think it's important that the CDC staff understand or get the message from CDC leaders that public health is as important as research. At the moment, the promotion system is built on papers and academic sort of aspects, but there are leadership tracks in public health, which I think should be evaluated as approaches to promotion and advancement. And I don't think that currently exists in CDC.
In the labs as much, right? And this is partly the issue of the fact that when you have so many teams at a lower level, it's in the hierarchy, it's just harder for people to be promoted just on the basis of, running a great lab.
Lynn.
Yeah, I wanted to actually, I agree with Nirav. I think that the culture is an issue. And I think that when you have a culture in an agency of people working in silos, just creating different silos doesn't necessarily fix that. And one thing that I found to be a bit dealt with I think too facile of a manner. And that is that not only do we need to have people who are doing lab work working together across silos, we need to have people doing lab work working together with epidemiologists, program managers, and others. You create new structures in an organization that works in a siloed fashion, you don't necessarily make the organization work better. This is a lived experience that I have with reorganizations, period. And I think to think that a reorganization will repair the culture is an illusion. It does not. It does not. A couple of things that I would say to the recommendations. I think that there is a lot of very strong shoulds in the recommendations that I'm questioning. I'm going to be frank. Should the leader report to the CDC director? Well, everybody wants whatever they care about. They want somebody who is a direct report to Rochelle. How many direct reports can she manage? Will that person actually have a strong voice if they're one of 20 people who directly report to her? I think what you're looking for is not the structure, the process. You're looking for an outcome, which is that that person is placed, in a high enough level, and that that person can influence policy, the flow of resources, the work with the external community, and allow the CDC a little more flexibility than you get with a should statement. Do we tell the Secretary of Health and Human Services that this is the only way that CDC can do this? That's where I have a little bit of qualms, not with the pros, the outcome you're looking for, but is this the only way to achieve that outcome? And I just think, that is the thing that everybody thinks. I'd also say, and I think you've already kind of touched on some of this, that definitely these issues that you're raising about centralizing around some of the key support functions like laboratory quality, safety, workforce, training, readiness response, manufacturing, that is really critical. And whether it's a CLIA lab function or not, you want the labs to be safe and to function well. And it could be just as important, either way, if it's a lab doing epidemiology, not clinical work, but epidemiology, if they're coming up with the wrong answer, say about what's the prevalence of lead exposure or something, that can have profound national implications as well. So I think that is really, really an important recommendation. And the only thing I think about adding to that, and it kind of gets into the next area, you want the research to be somehow feeding into the, either the clinical lab work or the work that, supports the epidemiology. And it is not clear to me that they have a strong, what I would call translational process for translating from the bench and what the researchers are developing to something that can become a CLIA test or that is validated, for the use in epidemiology, like who makes that determination. So I just wanted to kind of, raise that because I think that's part of what happened here. The piece so that whole issue of separation of the research from the CLIA functions, I get that, because, that's also part of my experience. At the same time, though, there's a should statement here, strict separation of space and staff. I'm not sure I can agree with that strong of a statement, that there might be things that are extremely specialized that are going on in the clinical lab space and in the research space where you might not want all of the staff to be separated, where they're just, a handful of people who have the knowledge and skills to be able to do certain things. And again, it just gets back to the way that this is stated, which is that I know what you're looking for as an outcome, but this I think could be interpreted to mean that you can't have a single person who, both walks into a research space and walks into a clinical space And when you're doing that, if you may, that translational work of taking the work from the bench into the CLIA lab, you might need that researcher in that clinical lab to help make that happen, even though that's not where they generally work. So I just think that the agency, I'm worried about people who don't know science reading some of this and thinking, okay, that's a line you have to draw, and you must not do X ever, you know, because it kind of reads that way. I mean, the rest of it, I mean, certainly the workforce issues, the lab quality issues, the culture around that, that's been a long-term issue for the CDC and frankly for some of the other federal agencies as well. And the need to bring in the external experts, definitely. The only other thing I wanted to say is that it feels to me that a lot of this is focused almost exclusively on infectious disease laboratory processes, and to remember that there are clinical labs in environmental health and other areas like lead testing, that we could have huge national emergencies, heaven forbid, you know, around radiation exposures, around chemical weapons, other things other than pathogens, things other than pandemic that might need to trigger similar kinds of lab responses. And I take what you say about, you know, it would be good to have all the labs in one place and fluidity, but actually CDC has a lot of labs that are not co-located. They're in different places, and they're not going to be able to co-locate them. They need to be able to manage around that too. And, you know, there's just realistically, there's only a certain amount of consolidation, and frankly, only a certain amount of mobility. I mean, if you work on malaria and that's what you do, you're unlikely to become a radiation lab expert, right? And be able to qualify for a job at a radiation lab. And it just, so again, to just be a little, I mean, I have ideas about places so one could do this, or maybe it's just in our transmittal of this to HHS to make it clear that, you know, we're more interested in the outcome than, you know, that there's an exact process that they have to follow to get there. Thank you. Sorry.
Thanks. Why don't we take Dr. Adammore's comment, and then we'll go back, maybe have a little more discussion on what Dr. Goldman's bringing up. Go ahead.
So thank you. First, you know, I wanted to say thank you. I really thought this was a wonderful report. It was fascinating to read, and I really appreciated seeing all these details. I have my question, and this is probably not a helpful question, but it persists in my mind, so I'll ask it anyway. You know, I wonder how much of what happened was at least in part due to what appeared to be the extraordinary chaos at the very top, not only the top of the CDC, but at the highest levels of government, which to me, I mean, I'm not a lab person, but could only have served to further demoralize and confuse people. And I like these recommendations because they seem to, you know, they seem to fix a lot of things that you and your careful assessment and the CDC itself felt went wrong. But that type of chaos could easily happen again in the future. In fact, it probably will, depending upon the elections of the next few years. And is there a way to make the CDC response more bulletproof? And I wonder actually, and I actually agree with everything in the report, but a question that I have is, it is good for the person to report to the director, but to the extent that the director comes under attack for whatever reason, what effect do you think that will have on lab performance? And maybe I'm way off base in terms of this, and that my assessment of things may not be correct, but I'm just curious about what your thoughts are, because I do, you know, I really just have this sense that there appeared to have been chaos, and I can't imagine how that did not impact the performance in the systems.
Jill, did you want to jump in, or I can get started? What do you want?
In terms of the reporting to the director, from my perspective, and being a director of a lab much less complex than CDC, it's important that the director know what's going on, what the challenges are, what the pitfalls are, what's working, what's not. The director must have that knowledge, because ultimately that's where the buck stops. Was there chaos outside? Absolutely. Although I think that the chaos was much more obvious a little later. I mean, I guess I don't think that the White House probably was even aware of what the CDC was doing, would be my judgment at that very early stage. I mean, I think at that very early stage, the administration was sort of downplaying the problem. So I can't, and maybe I'm wrong, but I feel that CDC was doing what it was supposed to do early on, not that much influenced by chaos. Now, having said that, being in public health emergencies, in a public health lab, there's a lot of tension. You know, people are working long hours, they're tired, but it's the communication and the reporting structure that mitigates the chaos, that controls the chaos.
So thank you. You know, there was a report recently released by the Science Committee of the House of Representatives in December that really talked about the relationship, for example, between the White House and CDC in great detail, tremendous detail, and all the different things that happen with MMWR and different components. It didn't get too much into the labs. I think our sense is that these were failures at CDC, you know, that not having a plan, the failure, not having a governance structure. We really focused by the kind of the four corners of this report on CDC. That's not to say, though, that there weren't major issues that were inhibiting the overall response. I think we really stuck to what can CDC do better. And the issue that you're raising is very, yeah.
I agree with that. And thank you for that. I was just curious about your opinion about how it could have affected. But I think, yeah, focusing on CDC was certainly, obviously, given your task, quite appropriate. Thank you.
And I think also, Ada, working under CLIA gives you a structure. You know how to do things. You know how to follow a protocol. And so from the clinical side of things, that's almost like a shield. This is what you need to do. This is how to validate. This is the pass-fail criteria. And that's actually very helpful to the clinical labs.
Let me just move back to Dr. Goldman's questions, because I do think we might be able to bring in a couple of the lab work group members to answer, to address some of the things that you're saying. Just to go through the issue of how consolidated, you know, we considered the recommendation to consolidate all the labs under one structure and decided not to do it. You now have a very decentralized system. And the recommendation actually does give FDA flexibility. It says, CDC flexibility. It says that, you know, ideally at the division level, but maybe at a different level, depending on what you think is the right one. Recognizing things like there are geographic distributions of the labs, and you know, there should be more than one person in the room, but you know, the smallest number of people who allow you to effectively manage the lab, and that's something for CDC to figure out. I'm not going exactly in order here, but I think it's worth talking about each of those things. There's also some flexibility in the discussion of the senior laboratory leader, because it does say at the end of that recommendation, you know, whatever structure the CDC feels best to accomplish this. I would just point out that CDC has done this. They have created a lab position that does report to the office of the director. And we think for very good reason. You know, this is such a neglected area of the CDC's, you know, governance structure overall, that it is really important. I'm sure maybe 20 other groups would make that case, but we're definitely making that case in this work group. And CDC, I think, has heard that and agreed. The issue about laboratories beyond infectious disease laboratories, this does talk about at multiple places, laboratories beyond infectious disease, and it recognizes specifically that the next one could be something that's different. and that the issues of workplace safety are for all labs, and so I think we want this to read like it's about laboratories generally, clinical labs particularly, no matter whether it's an infectious disease or a different kind of clinical lab, because you don't want to have gone through a huge, assessment and plan for one challenge and suddenly it's another lab issue that pops up because you haven't thought about that. So I do think that it is clear enough, but if there are areas that you think need to be more clear, we should look at that. The issue about learning how to translate research better is not something that we really focused on in the report. I think we respect research, but also see the function of the lab as the clinical lab. And there may be a set of recommendations for how to better translate research over, but I don't think it's so much within it was not part of why we felt the test failed. This wasn't a translation issue. This was a clinical quality issue and a governance issue. And so that's the reason why you don't see a whole section, I think, on that aspect of this. It probably would require us to go all the way back and think about, what research translation looks like and how it could happen. I'm not saying that, wouldn't be a useful exercise, but really wasn't what we focused on here. The last one, I think, is the something that we should bring a couple other people into the conversation on, has to do with the separation of clinical and research lab space and functions. And the lab work group had a number of people who work in, very high-tech lab situations where there is research going on around them, and thought about this particular recommendation quite a lot. And it may be worthwhile just to have a couple people chime in. I don't know if Daniel Rhodes is here. Maybe just introduce.
Dan or Angie.
Yeah,
Angie Caliendo.
Angie Caliendo and Denise Tony, if you all could turn on. So Daniel, anything you wanted to say about that?
Sure. Yeah, I can just add some commentary around this discussion. So I work at Cleveland Clinic, and I'm a physician, and I oversee the microbiology diagnostic laboratory here. And I also work with a team that does research, clinical research, and those two teams are mostly separate in their function here. I think from our visit with the CDC, it seems to me, with my limited interaction with the CDC, that there's a strong priority, there's a strong culture around research. And I think that's important and that's great. But at the time when COVID emerged, it seems to me that the clinical labs the clinical testing was rolled up essentially inside the research laboratories. And this is, in my opinion, if it remains that way, there's always going to be tension and differing priorities. And if research is a priority, then clinical diagnostic laboratory testing potentially is less of a priority. There's a lot of, as you know, there's a lot of CLIA regulations, competency maintenance, proficiency testing. And when scientists in the morning are doing research and in the afternoon are working in the clinical environment, it's going to be hard to do that successfully. And I feel like we saw an unsuccessful attempt with the emergence of SARS-CoV-2, and together with the work group, I still feel that breaking out those focused on diagnostic testing into their own group, where that is the only priority for that group and where they can put all their effort, I think it could lead to better outcomes in the future.
But Daniel, I thought you just said that you do that you work in the research setting and then you go work in the clinical setting. And so what's written here is there would be strict separation of space and staff. And at CDC, you would be called staff. I just want to be clear. You're saying they can't do what you do.
No, I was talking about, or I was thinking about, maybe I didn't say it clearly, the people who are actually doing the pipetting on the bench day in and day out, the people doing the testing, manipulating the samples, signing off on that they're competent in doing the testing. I think it's good that the people on the bench can focus either on research or on testing. Now, will it be like that 100% of the time, every time? Probably not. And like you said, there's a lot of these tests translate from research into the clinical lab. And so there should be a good handoff between those doing the early development to those who are validating it and using it on clinical testing.
I want to see if Dr. Caliendo wants to jump in on this at all, and maybe just introduce yourself a little bit to the group, Dr. Caliendo.
Yes, I'm Angie Caliendo. I am currently Vice Chair of Medicine at Brown, but prior to that, I spent about 20 years in clinical laboratories and directing clinical labs. And it's interesting, the point, Lynn, that you bring up, because I initially had my research lab embedded in the clinical laboratory, and it did not go well. And what I ended up doing is pulling and separating out my research lab and getting my research lab CLIA certified. And the reason that was done is you need a culture of quality, even in a research lab. I was doing testing for clinical trials, and so we kind of came to this conclusion that the best case scenario would be the separation, so that people that are doing clinical testing are focusing on the quality program around clinical testing. And then researchers need more flexibility. If there are, and you gave a scenario of something that is so specialized that you cannot separate the clinical from the research, then you're going to have your researchers live in a CLIA environment. And that's very different than what exists now at the CDC. What we saw was, and I think it led us to say that the person overseeing all the laboratories reports directly to the director, because it gets at the question someone raised earlier about culture. And the culture at the CDC has a different hierarchy. For research labs are here and clinical labs are here. We need to elevate that culture of the clinical labs and what separates them and makes them different from research labs. So there may be situations where you can't have full separation. And in that case, then you need to default to the higher level of quality oversight.
So in a way, what you're saying is that first of all, that the staff separation is intended to mean the laboratory technicians, basically, more than and second of all, that the separation has to be that if there is an overlap, that the quality standard, like a significant overlap between research and clinical, the quality standard that should be adopted is a clinical standard.
And that goes not just for the technologist at that point, but then the director of the lab, right? If you're going to do clinical lab testing, then that person has to be trained in clinical laboratory.
Right. Where overlap is inevitable, it should be at the clinical lab standard. So this would be a way that we could revise this particular recommendation. I want to see if Dr. Tony wants to jump in with anything. And just introduce yourself, Denise, for a second.
Hello, I'm Denise Tony. I am the laboratory director for Virginia's State Public Health Laboratory, and we are a CLIA accredited laboratory. I did want to make a couple of comments. The comment about when a test is moved into a clinical diagnostic lab, that there may be a need for input from the researcher. I feel as if a test is properly validated and developed and it's robust enough to be moved into the clinical diagnostic sector, that lab should be able to run that test without the need for input from that researcher. Because if you still need input, then it's not ready for clinical diagnostic testing. It should be able to be quickly validated or verified and then be put into action, especially if we're dealing with an emergency. And then along the lines of CLIA and having this culture of quality and a strong quality management system, I can say in my own lab, we do have research functions, and then we have separate diagnostic functions. And really for those diagnostic functions and those laboratories to operate seamlessly, there needs to be structure and repetition and consistency. And those are essential to maintaining all of the compliance factors that you need for quality. And especially when the system is stressed, that's when that training and consistency is so important, because if you are teetering back and forth between a research mindset and a quality diagnostic mindset, and you're tired and you're stressed and there's lots of pressures, that's when you're going to make mistakes, and that's when best practices don't happen. And so that separation really is important and is a best practice if we want to ensure success and accuracy of the work that comes out of our laboratories. Thank you.
Well, just very quickly, first off, thank you very much to the laboratory working group members that have joined us. It's very valuable. So it's been a really productive discussion. If you are willing, I'd like to ask that we move forward to complete the recommendations. I'm watching the clock a little bit here, and then we can have a bit more discussion, but I want to make sure we get through.
Great. I think we probably hit the most challenging parts of the recommendation, and this is great. And why don't we proceed?
Can we have the slides back up, please? Oh, yes. So action step 7. So Josh brought up before the fact that we need a national laboratory system. And CDC, I think up to this point, has seen itself as freestanding and connected, but not integrally part of the national system. And I think that the pandemic has shown us that one entity can't do everything. CDC and public health have a role, clinical labs have a role, commercial and academic labs have a role, manufacturers have a role. And we need to have this conversation nationally about a national lab system with CDC at its center. And that means that CDC needs to be much more outward facing and involve external experts in its review and deployment for pathogens with pandemic potential. And it's, I think, a change in focus for the CDC to be much more outward looking and to involve external experts. Josh?
I would say keep going. That's good.
Okay. Next slide, please. One of the problems that we feel was very crucial for the failure of this test is that there was no redundancy. CDC was developing the test, and the external labs, public health, academic, commercial, were not taking a role. And certainly in New York, we had delayed validating our own test because we knew the CDC was developing the test, and this is the way it has been. But I think going forward, we need much more redundancy in the initial stage of a pandemic, not just public health, but certainly academic and commercial labs should be involved in test development, so that you've got multiple versions of the test available in the nation to, if one institute goes down or one test fails, that you have more redundancy. So we think that this is very important. Next slide, please. One thought that some of our labs had, there's a huge load on CDC, and in many ways it's sort of the reference lab of all reference labs in the country. But there are a number of very competent high complexity labs around the country who have the ability to test for rare agents. The CDC has recently funded centers of excellence in genomics that are a collaboration between public health labs and academia. And the work group feels that using that model to develop centers of excellence for diagnosis of other rare pathogens would be of value. And then the next slide, please, which is our last action step. This addresses the data issue. I think everyone is totally aware that data transmission and data information, the system is incredibly complex. And so the work group felt that it was not possible for us to do a huge analysis of where the country was. There's a lot of other entities doing that. One thing that we do feel is, and that CDC certainly can take the leadership on with public health labs and other clinical and commercial labs, is looking at standardization of health data collection and determining the minimal data set. And we think that CDC should take the lead here, but involve partners in that. And I am aware that that is already happening with CDC and CSTE and also APHL, not only for case minimum data set, not only for case reports, but for permission to perform a test. So that's something that we feel quite strongly. I think that's our last one, and the next slide should say discussion. Any other additions there? Any other questions?
Let me just add that for that last one, we had a little bit of engagement with the data work group, I think very consistent with what Julie was presenting earlier today.
Yes.
Julie.
Yeah, thanks so much for the presentation. I was flipping through the report that you shared with us, and I was so pleased to see that in your first recommendation that there actually is inclusion of that director or that person reporting to the director has the responsibility and authority to require of laboratories these things. And I think that's really important, because I guess it was getting to the heart of my question of Dr. Walensky in terms of these offices being separated from the centers. They really need to have the authority and responsibility to make sure that these things actually happen. And so I was really pleased to see that you called that out explicitly. So just thank you for doing that.
And Julie, I read, so the other Dr. Shah, where is Dr. Shah? So there's two wonderful Dr. Shahs, and Dr. Shah from Maine is joining at CDC as Deputy Director. And I believe that Dr. Walensky has given him the task of really taking the lead on lab issues. And so I'm really excited by that.
Well, I've heard an incredible presentation, great questions, really good discussion. I'd like to begin to move us towards a vote to accept the report of the committee. Josh and Jill, in a moment. First off, we checked, and it's actually very appropriate for the committee to approve the report. And if there are a couple of issues around fine wordsmithing or issues that could be added in a letter of transmittal, that can be added after the fact, as opposed to something that needs to be included prior to a vote. Josh and Jill, I'm wondering if I'm going to give you a moment to reflect on the discussion we've had and identify whether there are a couple of areas that you might want to add a few words, for example, with respect to some of the separation issues, flexibility, culture, et cetera. But while you're thinking about that, I did also want to give the floor for a moment to Deb, just to give a little bit of CDC's perspective on this and the discussion that we have had. So over to you, Deb.
Great. Well, thanks so much. And again, Josh, Jill, Lab Work Group, really appreciate the depth and breadth of the report and the recommendations. You know, as I was listening, a few things I was reflecting on, and one, Dr. Fleming had mentioned, these issues happened 3 years ago, and certainly I think it was Jill or somebody else that mentioned these have been long-standing issues at CDC as well, but we've not been waiting to address them since it came to light. And you've highlighted a lot of the progress we have made. It's something that's been a top priority for Dr. Walensky. And as we're talking about the reorganization, I did want to highlight that we realize that moving boxes doesn't solve things. And that's why we have the whole CDC moving forward that, includes the 21 priority action teams that also looks at our systems, our processes, how do we change culture? And we've engaged staff at all levels to really empower our scientists, our practitioners to be engaged in this. Another thing we've done is we now have a response ready workforce that Rochelle has talked about so that we are ready for the next response and that all staff are poised and ready to join responses. And we've revisited things like our graduated framework as well for responses so that if it's program, center, or agency, we're prepared to stand things up. And I agree about the quality management system. We're currently piloting it and we're looking to have it agency-wide under the leadership of Dr. Perkel. And I did just want to thank all of our staff, both our lab staff, but also all the staff that worked tirelessly 24/7 during the response and have kept all of our other programs at CDC going on. I know that y'all mentioned morale. We have a resilient, amazing group of staff and scientists and administrators, practitioners that I am so proud to be, shoulder to shoulder with. And I did just want to thank them as well. The one piece of housekeeping I'll just say while I have the floor is, as you review the work group report and vote if approved, then the report will be transmitted to HHS. And that takes about 30 days to review and respond from HHS. That will then be published to the website. So for folks that are tuning in or work group members that want to revisit it or share, it'll be about 6 weeks before the report will be publicly available on our website. Thanks, David.
Thanks, Deb. That's great. Let's now begin the process of moving forward to a vote. And Josh or Jill, I wonder if you could make a motion for adopting this report and translating the action steps into recommendations. And please, if you would mind mentioning, just if you see a couple of areas where you might want to do a little bit of wordsmithing in advance. And before you get to that, I see that Octavio, you have your hand raised.
Yeah, thank you, David. And sorry, right before that, but just want a clarification on some of the guidelines you're giving to Josh and Jill, just so that I'm clear, because it was such a robust discussion. And two themes that really came out to me were, one was really organizational, cultural, laboratory behavior. And the other one was, and I really appreciate Lynn's insights and the discussion that followed, unintended consequences of the recommendations themselves. And given the discussion, at least from my, because I'm not a laboratory research guy, it would be nice if those two issues, even if it's just a few sentences, were addressed. Or at least I know, like you said, it could be after the fact, but how's the discussion going to be incorporated? So maybe that's a Jill and Josh question.
Sure.
Yes.
So I have a little list that I would suggest that would be sort of for those adjustments to the report based on this conversation, and also based on a comment, Octavio, that you sent us beforehand, which was just, I should just mention also, which is to point out, so I've got, I think, 6 items on my list, so I could go down them real fast.
Yes.
One, Octavio, you had made the point that when we have a senior lab leader who's going to engage with other agencies, that part of their remit include the supply chain, or at least CDC's engagement in the supply chain. And so we would just add that to the text around there. So that's number one. Number 2 was when we discussed plans to talk about exercising the plans. Number 3 was to add a robust, diverse workforce for the lab. Number 4 was to modify the language around the strict separation between research to be a little bit more clear about what we mean. And that would be that we would discourage the use of technicians who would work in both in a research space that is not being held to a clinical standard and a clinical space that is being held to a clinical standard. And that those spaces should be different, that if they're 2 different quality systems, it should be 2 different spaces. That is, and then the last one would be related, which would be that if there is an inevitable need to have a shared research and clinical space, that it should be held to a clinical standard. of quality protocols. So those would be the changes to kind of adjust with what I thought was a great conversation with Dr. Rhodes, Dr. Caliendo, and Dr. Tony.
Absolutely agree. Thank you, Josh. Let's go ahead. If one of you would be willing to make the motion, we'll have an opportunity for some final discussion, but just to get the motion on the table.
Sure, I'll move the report
And the adoption of the action steps as recommendations.
and the adoption of the action steps as recommendations of the ACD.
Is there a second? I see Julie seconding. Thank you. Any further discussion at this point?
A little worried. Dr. Goldman looks like she may have frozen. Midpoint.
Uh-oh.
Reaching for the mouse, perhaps.
There you go. Well, I'm sure that she would understand. We can connect with her afterwards. In listening to her comments, which were great, I think that you've incorporated them, and if by chance we've missed any, we can hear from that. But let's go ahead and then take a vote. All those in favor of the motion of adopting the report and making the action steps proposed as official recommendations from the ACD signify by raising your hand or saying aye. Aye.
Aye.
Are there any opposed? Any abstentions? Fantastic. So the report is adopted unanimously with the adjustments that will be made by after the fact by Josh and Jill, according to what we just talked about. Thanks very much to the ACD, and most importantly, my goodness, thank you to the laboratory working group and our fantastic co-chairs for taking this very, very difficult job and really creating a clear and succinct report, as people have said, with a series of recommendations now that are going to make a huge difference to CDC and to public health in the future. So thank you, folks, very much. A virtual round of applause.
Well, thank you. And thanks to you, David, for your guidance throughout the whole process. And a special thanks to Dr. Howery for really organizing so much to make this all possible, and really to CDC for its critical work and unquestionable movement in the right direction on this difficult issue.
And I think what we learned helps us all in our own organization. So thank you very much.
Wow, well, I have a profound sense of accomplishment, not only for the session that we just had, but for all the sessions today. Really, really appreciate the work, starting with Dr. Walensky and her update and moving forward, and the insights that she's brought to CDC is quite remarkable. And Dr. Dauphin for her review of this incredible new sector that CDC is creating, and the public health workforce initiative that's going to make a big difference. And then special thanks really to each of our working groups and our co-chairs, Julia Narav in the Data and Surveillance Working Group, and we'll be looking forward to the next couple of meetings when you have done further work on those issues you laid out today. And Monica and Daniel for the work to date, including the approval of the one task area and the exciting work that you're going to be doing on those other two task areas. And then Jill and Josh and the work that you presented today. And the good news for the committee and for CDC is that was only one of the terms of reference of the laboratory working group. And so
we'll be back.
right. You will be back. So thanks to all of you. I'm going to in a moment give you, Deb, the last word for the meeting today, but do want to express my personal appreciation, in addition to the ACD members, to the incredible staff that we have at CDC that have been working tirelessly behind the scenes really to make all of what you've heard today happen, as well as seamless mechanics of the meeting today. And special thanks to Deb, who's stepped in for John in a just incredible way, made a huge difference already, and is just a real asset to this committee's work moving forward. So thank you very much. And just before I give it to you, I'm smiling. I'm seeing Lynn put a note in the chat that she did get bounced off, but she votes an emphatic yes on the report. So we'll add that to the official vote total. Over to you, Deb, for any last words.
Well, I want to echo what David said and really thank all the work groups. I personally am really excited for the action steps and recommendations that have come from today's really robust discussions. And what I've really seen over the past year with the ACD being reconstituted, it's been really great to have all these external experts with your opinions on and advice and expertise on health equity, data, as well as certainly lab. And really, when we presented our responses, talked about communications, hearing from you on where we can continue to do better, as well as also appreciating, what we do. I know our staff really appreciate hearing from all of you, but it's been an honor and a pleasure to work with all of you. And I'm excited to see you in person in May.
I think that date is May 9th is where it's currently scheduled. We'll be getting back to you with the specifics of that meeting. Thanks, Deb. Thanks, everybody. And with that, we are officially adjourned.